Salam and a very good morning to all of you. I'm Rumana from Faculty of Medicine, University of Malaya. On behalf of the Center of Epidemiology and Evidence-Based Practice and Center of Excellence for Research in AIDS, let me have the pleasure to welcome you all in this morning's webinar titled HIV Research and Practice Impact in Resource-Limited Setting. Our speakers for this morning are celebrated professors from Yale School of Public Health and Yale School of Medicine, Professor Sten Verman, Professor Rick Altis, and Professor Sheila Shenoy. None of them need an introduction. Before we open the floor to our distinguished speakers, I would like to invite Professor Rabza Ahmad Zaki from Department of Social and Preventive Medicine, Faculty of Medicine, University of Malaya, to make the introductory remarks. Over to you, Rabza.
Okay, can you all hear me? Yep.
Clearly.
Okay, Assalamualaikum and good morning. Thank you, Dr. Rumana. So I'm Dr. Ramsah, currently the head of the Center for Epidemiology and Evidence-Based Practice. So this webinar is co-organized together with the Center of Excellence for Research in AIDS, or CHERIA. So CEBP and CHERIA, we would like to welcome you to this seminar. So I especially want to welcome our speakers, Prof. Dr. Sten Verman, Prof. Dr. Frederick Altis, and Associate Professor Dr. Sheila Shenoy from Yale School of Public Health. So we are very honored to have you in this webinar. We also would like to thank each of you who being here with us today. So we actually received a we received an overwhelming response to this webinar. According to our registration record, we have more than 150 participants registered to this session. So we actually broadcasting this event on YouTube Live to cater for the high number of participants. And we have participants from various organizations, including from universities, Ministry of Health, and NGOs. So thank you again for your interest and support to this webinar. So this webinar is actually inspired by the collaboration between UM and Yale under the Malaysian Implementation Science Training Program. So the title of this webinar is Optimizing HIV Research and Practice Impact in Resources Limited Setting. Malaysia actually has been battling HIV for almost 40 years. With the first reported cases of HIV in Malaysia was in 1986. So there are now over 100,000 of reported cases of HIV in the country. Although there is some reduction compared to the past 20 years, the trend of HIV cases in the past 10 years remain almost static, with the cases between 4,000 to 5,000 per year. And in 2021, Malaysia reported about 2,760 new cases, which is among the lowest within this decade. However, we need to remember this number is actually not reflecting the true picture, because that was actually happened during the COVID-19 pandemic, where we know that during that period, the community-based HIV screening and the prevention and detection activities were disrupted because of the pandemic. And in fact, Malaysia is still off track of its goal of attaining the 95 in testing, treatment, and viral suppression target. Actually, there are many programs and research that have been carried out to fight HIV. However, we don't know how many of these studies or program has been successfully implemented in real setting and achieved the optimal impact that has been shown by research. So today we are pleased to hear from the three outstanding speakers who will share their knowledge and experience in HIV and also their expertise in implementation research, particularly in relation to resource constraint setting. So I don't want to take so much of your time. So we're all excited to hear from the speakers. So hope you will enjoy the session, and back to you, Dr. Rumana. Thank you.
Thank you so much, Professor Rabza, for making the introductory remarks. Our first speaker for this morning is a respected professor, a talented scholar, and everyone's favorite, Prof. Stein Verman, the former dean of Yale School of Public Health. By training, Professor Stein is an infectious disease epidemiologist focused on diseases of low and middle income countries. The title of Professor Verman's presentation is Identifying Solutions to End HIV Epidemic Through Implementation Science. Professor Stein would have 45 to 50 minutes to deliver his talk, and then the audience can drop their questions in the chat box. The question and answer session will be for 15 minutes. Over to you, Prof. Stein.
Thank you so much. Can you hear me all right?
Very clear.
Yes.
Oh, wonderful. So you've given me a very challenging topic, but it's an exciting one. Let me just define implementation science. There are many definitions. This is one that I like: a systematic approach to the design, delivery, and evaluation of strategies to promote the uptake, adaptation, and maintenance of evidence-based practices. So this is one way to think about it. This is from a Harvard website. And we have different phases of research: early, middle, late, and real-world relevance. Not yet. It's getting there, and highly relevant. So one thinks about pre-intervention research that might include laboratory science, animal studies, and then efficacy studies. Can you actually take something that looks promising and prove that it's efficacious? Then bring it to public health practice. Can you roll this out? Will people actually use the intervention? And then implementation studies. What makes the program work in real world settings, such as clinical practice, public health practice, and the like? It's always good to think about implementation from the outset, but sometimes we find things that don't seem implementable, and then some technological achievement, we find out that now we can implement it. Pre-exposure prophylaxis comes to mind. Have we been wildly successful worldwide with PrEP in preventing HIV? Not particularly. On the other hand, some of the injectables in which we can give an injection once a month, maybe once every 6 months, might be game changers in terms of the practical exposure. Another way to map it is sort of a little more on the basic science side, a little more on the clinical science side with randomized controlled trials, public health science, and then ultimately scaling up to real world application, namely implementation science. Oops, I'm going the wrong way. So there's a myriad of subsets and themes linked to implementation sciences: health services research, outcomes research, clinical effectiveness or clinical epidemiology research, quality improvement research, operations research, knowledge translation research, complex interventions research. And to be perfectly honest, these are overlapping Venn diagrams. These are linked concepts, and I don't lose much sleep over what I'm going to call it. If I'm in the space of trying to bring a known good to wide application, then I'm doing something in this space. Now, why implementation science research in HIV/AIDS? So I'll just give you two short vignettes. When I left the National Institutes of Health, where I worked, to go to the University of Alabama at Birmingham, less than a year after I arrived, there was a nearby clinic, less than an hour drive from my office, which was destroyed by an arsonist in a small town in Alabama. And we had antiretroviral drugs. We had prevention measures, but we also had stigma and hatred in our communities that substantially undermined the evidence-based medicine and science that we were practicing. This arson event was homophobic, was an event that really was trying to destroy the spirit of both persons struggling with HIV disease and also their providers. A second vignette is what greeted me when I started working in Zambia in South Central Africa. This was a church project, the Rise Christian Gospel Ministry, and their youth project was building coffins because we were filling the cemeteries of Lusaka, Zambia, a city of about 2 million people, the capital city of the country. We were filling the cemeteries. All of the major traffic jams in town were due to funerals. And the number one cause of absenteeism from the project that I was directing was going to a funeral. So I'm going to give you 7 global implementation science research examples. And I've chosen to choose from my own work simply so that I can make it more interesting for you, since my own work I know better than others. So I'll talk about scaling up cervical cancer programs within HIV programs, implementing prevention of mother-child transmission, tackling suboptimal adult and child HIV outcomes, poor antiretroviral therapy coverage for pregnant women. I'm gonna divert from the HIV theme to talk about vaccine coverage, which is not HIV related, but I think it's worth a slide, and integrated prevention of mother-child transmission schemes in Asia, and suboptimal progress towards our goals in the United States. So number one is the challenge of cervical cancer screening in persons at especially high risk. Number one on that list are people who are immunosuppressed. And even a woman who is on antiretroviral therapy is partially immunosuppressed. We've never succeeded in completely normalizing the immune system in women with HIV. We substantially slow disease, but there is ongoing inflammatory reaction and inflammatory processes. So women with HIV who are untreated are at the highest risk, but women who are treated are still at risk of HPV mediated cervical disease. And you can see HIV rates, death rates from a few years ago in the left, and you can see cervical cancer rates in the right, and you can see how the maps overlap to some extent, particularly in Africa. Now, with HIV, we have about 4,000 people per day who are infected, and with current trends, there will be 1.2 million new HIV-infected persons in 2025. That's 3 times the 2025 target from UNAIDS. And with access to ART being improved, women are living longer in an immunosuppressed state. So there are a lot of people getting infected and a lot of survivors. Now, cervical cancer has about 600,000 new cases every year, about 340,000 deaths every year, indicating how many of those cases present, particularly in low and middle income countries, with advanced disease. And of course, our goal is to screen and prevent. 90% of the deaths are in low and middle income countries, and it ranks either the first or the second cause of women's cancers. HIV infected women have 6 times the incidence of cervical cancer than others. Now, here's why I think of this as implementation science. Here's why I think of it as implementation science. You can think of it like a Swiss cheese. So women do not come in for screening and get through a hole. Healthcare providers don't screen. When the women are there, there's another hole. Colposcopy for an abnormal screen is not done. There's another hole. The patient is diagnosed but doesn't get appropriate therapy. There's another hole, and ultimately the patient gets cervical cancer. So it's a perfect implementation science challenge. We know the cause, we know how to prevent it, we know who the target populations are, we know what the needs are of programs. What we don't know is how to scale it up given resource constraints, how to integrate fully with existing health systems, such as HIV clinical services, and how to effectively engage communities. Now, we've done a lot of work in this space, and I'm just going to show you the very first paper that we wrote back in 2006 under the leadership of Grosbeck Parham and Mulindi Mwanahamuntu. And we took 150 consecutive women who were coming in for HIV care. So all of these were HIV infected women. And we simply did a pap smear in each of these women. And you can see that over half of them either had suggestive cancer lesions or had high grade squamous intraepithelial lesions. So this is a very unusual population to screen. I mean, if we screen a normal population, one would find a tiny fraction of this amount of pathology. And only 23% of them were either normal or had atypical squamous cells of undetermined significance. So this was a clarion call that if we implemented HIV care without parallel cervical cancer screening, we were going to have what the surgeons sometimes say, the surgery was a success, but the patient died. We were going to have a successful ART program, but the woman was going to die of cervical cancer. So we were able to coax donors, particularly from PEPFAR, the President's Emergency Plan for AIDS Relief, to support our program. And we were able to grow our program by leaps and bounds, because guess what? If you got local women to explain to the patients why we were doing this strange activity, putting women in the lithotomy position and putting a speculum into their vaginas. This was not something women had experienced in this part of Africa. They were unfamiliar with it. And we had to have local women explain why it was important and why it was going to benefit them. And then the women said yes, overwhelmingly. And we focused on HIV seropositive women here in the red, but we took all comers. And it wasn't long before a majority of our folks were either seronegative or serostatus unknown. Now, the serostatus unknown and seronegatives, of course, were offered HIV testing. Let me move on to, by the way, now we cover the entire country of Zambia, and I think we're a model program for the entire continent. And we've trained people from over 30 countries now in our Zambia program. Let me move on to a second theme, and that is, how do you engage nurses, communities, men? How do you reform clinics to maximize HIV success when you actually have HIV programs available? So PEPFAR made that possible. A program started by the US government in 2003 radically altered the opportunities that we had to intervene around the world, particularly in Africa. And here in Lusaka, we had already begun working on HIV care pre-PEPFAR, and I'll share a little bit of that with you. So this is a cascade for prevention of mother-child transmission. In my first life, I was a pediatrician, so I've naturally had an interest in mothers and children, very much in my clinical background. And you had to have women come to the antenatal care if you were going to be able to offer them the program. And we had about 10% of women who were delivering at home, even in the urban area. And so we needed to do some community efforts to try to encourage them to come into antenatal care. Then we had to offer the intervention. So we had to start a voluntary counseling and testing program. And at that time, we were using single dose nevirapine. Now we use comprehensive ART for pregnant women, of course. But at that time, with severe resource constraints, we were using a sort of basic intervention. And they had to be offered it. So you had to have a functioning HIV testing within antenatal care. Then you had to have, the women had to uptake the intervention. They had to agree to taking this medicine. And then they had to remember to take the nevirapine when they went into labor. So they had to adhere to the intervention. And then we had to have functioning postpartum services so that the right baby was identified before discharge to get the baby's dose of nevirapine. And with this single dose nevirapine for mothers, single dose for the newborn, we could drop transmission by more than 50%. With exceedingly low costs. So in 2002, when we started working, we had less than 5% coverage. By 2004, we had done a citywide survey and we had increased it to 30%. But 30% was not what we had expected. We thought we were doing much better than that. So that then enabled us to do quality improvement work at each and every one of the 26 clinics providing antenatal care in the city. And we were able to increase coverage by 10% per year to about 60% in 2007. And now we have better than 95%. Here's a picture of a community worker introducing a drama group. And when we started designing posters and media, our staff said, no. People are not going to respond to a poster. People are not going to respond to media. They will respond to street theater. And we hired this community theater group in 2004, I think it was. And they've been working for us ever since. And this was a way to get the word out to the community about the benefits of being HIV tested for pregnant women and ultimately for everybody. So there's a large body of work that we had in this area to try to describe our struggles and eventual successes in this implementation science arena. So let me go to the third topic, which is quality improvement to expand HIV coverage in rural Mozambique with the support of PEPFAR resources in collaboration with the Mozambican Ministry of Health. Now, Mozambique is one of the 5 poorest countries in the world when you look at the World Development Index, somewhere in the 5 to 10 poorest countries range. PEPFAR, for those of you who don't recall, is the largest health-focused foreign aid project in global history. It dwarfs the expanded program on immunizations of WHO. It dwarfs polio eradication or smallpox eradication. It's the investment from the U.S. government has been $110 billion through last year, and this year's budget is $7 billion. So this is a small clinic in the area where we were working. So a medical student identified that infant retention was very poor. Only 25% of all the HIV-exposed infants were brought for an initial visit for testing. As you know, very difficult to definitively diagnose a newborn with HIV, a lot of interference from maternal residual blood, and so it's best to diagnose after a few weeks with PCR. And so we wanted to bring these infants back after 1 month for definitive testing, and only 1 in 4 was brought back. Meanwhile, about half of the mothers were retained in HIV-related care. So I knew something was fishy here because mothers always watch out for their infants better than they watch out for themselves. So we recruited, well, first, let me just show you, this was sort of the backdrop. We had 61% of HIV-infected children were either dead or lost to follow-up by 24 months. Although we had massive improvements subsequently, thanks to our implementation science, it gives you a sense of just how badly we were doing in terms of HIV care for infants and to some extent for mothers in rural Mozambique. So we brought in a process area expert, an American, Phil Chiampa, a Mozambican, Jose Tiki, and we did a process map, and many of you are familiar with process maps. You simply track how women are being seen in the clinical environment. So in the maternity ward, the woman would come in, HIV status assessed. If she was HIV infected, prophylaxis given, infant delivered, prophylaxis given to the infant, and counseling and early infant diagnosis clinic referral. And the mother was discharged to come back a month later. And the clinics were only 50 meters apart in most of our venues. They were in the same compound, and so it didn't seem too hard for the woman to be able to come back in a month. But this is the failed system. This is a process map of what was only getting us 50% of the moms and 25% of the infants. So what did we do? We interviewed the nurses. We interviewed the mothers. And the mothers and the nurses told us exactly the same thing. Number one, they were confused by the advice they were given because the healthcare staff largely spoke Portuguese. Many of them were from other regions of the country, so they did not speak the local African language. So they spoke Portuguese, but the mothers only had a median time of formal schooling of 2 years, men only 4 years in this very rural part of one of the world's poorest countries. And so they didn't have the facility with Portuguese to understand a complex message. You have a virus, but you don't feel sick. You may or may not have passed that virus off to your baby. Your baby may or may not have the infection. We can't do a test now because we have to do a test in a month with PCR. And then we have to take care of you. And even though you don't feel sick, we have to treat you with medicines. This is a very complex message, okay, for women who are hearing it in a foreign language. So this was what was broken. So what did we do? We took the nurses' advice and we said, the nurses told us, look, we can simply, in postpartum care, instead of discharging the mother, we can walk the mother over the 50 meters across the dusty courtyard to the early infant diagnosis clinic and to the HIV clinic for herself. We can get her counseled by a lay counselor speaking the local language. We can enroll the mother, we can enroll the infant. And in social science, this is called the hot handoff. This is direct accompaniment, registration of the mom and baby, local language explanations. And that's what happened. An 80% increase in babies coming back for early infant diagnosis, a comparable increase for women. And by the way, as we rolled this out, it got better and better and better over time. So, you can practice medicine for a long time and not have this kind of impact that you have with a single structural evaluation and structural reform that we were able to achieve in rural Mozambique. We also found that a lot of moms were being lost to follow-up. So we recruited Carolyn Audette, who was a medical anthropologist, and she worked with her Mozambican counterparts to interview mothers and find out why they were reluctant to come back for care. And some of them were reluctant to get HIV tests to begin with. And the general theme was, we're worried about our husbands leaving us. We're worried about our husbands blaming us. So fear of the partner's response. So we launched what we called a male champions program, where we recruited the men who were the most popular in the community. They were the best soccer players, football players. They were the best farmers. They were the best merchants. They were the ones who told the funniest stories at the local bar or shabin, whatever made them respected by other men. And we recruited them and we hired them part-time and paid them to recruit the men to join their HIV-infected women partners, or wives usually, in the clinic environment and get tested themselves. So what happened when there was no spouse or partner participating? We had these very high loss to follow-ups, almost 40% in just a year, and we were able to cut that in half if the spouse was recorded. And this similarly got better and better over time. So these were strategies. We weren't discovering whether HIV could be treated with ART. We knew that already. We weren't discovering that you had to have long-term ART to have the optimal result. We knew that. What we were doing is figuring out how do we deploy ART in real-world settings with maximum fidelity. We also did some work both in Mozambique, but I'm sharing some work from Kate Klaus and her South African colleagues. There was a belief that the care for the mother was sort of done after healthy delivery. This is what the nurses said. I think they don't care about their lives. Excuse me, what they wanted was to give birth, nothing else. When they see that their babies are well, they don't see a need to come back to the clinic anymore. And most of the pregnant women take their medication only to prevent passing on the virus to the baby and don't care about their own health. So these were sentiments from the nurses as to why we had lost to follow-up among the women. Now, the mothers themselves said that I didn't have a problem with adherence because even at work, I used to take my tablets. What are those tablets for? I said it's because I'm pregnant. However, after delivering the baby, they didn't have an excuse to take the pills. So some of them stopped taking. Sometimes women lied to their partners and told them they were taking meds for pregnancy. So after birth, what will they tell their husband? So these were insights from qualitative science that were incredibly helpful in our trying to work with families and mothers to minimize loss to follow-up. Another area is kind of the structural underbelly of HIV programs. And in Mozambique, again, one of the world's poorest countries, one of the least capacitated, we had a major problem with pharmacy stockouts. And we've found that pharmacy stockouts, nobody ever wants to talk about them because it embarrasses the Ministry of Health. It embarrasses the NGO that might be facilitating the programs. It embarrasses the local officials. It embarrasses the pharmacists. It embarrasses the people who are responsible for drug logistics. And with adult ART, we had a problem. When it's black or red, it's a serious shortage. In pediatric ART, it was even worse. You see a lot more black and red, and even with TB medicines. And I didn't show it on this slide, but we also looked at test kits, HIV test kits. And, you know, when somebody says, yes, I would like an HIV test, but there are no test kits, imagine what a missed opportunity that is. Or somebody has successfully been managed on triple therapy, but now they come in for their drug renewal and that their drug is stocked out. What are they going to do? And we found that a lot of times a substitute was not provided. They simply went on dual therapy instead of triple therapy, which we know is a catastrophe when it comes to drug resistance. Now, this kind of work is not widely done because of what I said earlier. It's politically fraught. It took us 2 years of negotiating with the local authorities to permit us to publish these data. And we had this led by Mozambican investigators. And that, I think, made all the difference. Now, sometimes you end up with research opportunities that are almost accidental. And a woman named Meredith Blevins, who's the co-first author of this paper, and her colleague Brian Shepard spearheaded this study. She noticed that our definition of loss to follow-up in our program differed markedly from various definitions in the literature. And she brought this to my attention, and she said, you know, it doesn't make sense that that everybody is not using the same definition for loss to follow-up. And I said, Meredith, you're absolutely right. Let's do a deep dive on this. So we found 17 different definitions of loss to follow-up from the literature, and we applied these definitions to our Friends in Global Health, that was the name of our NGO, cohort in Mozambique. So each definition was applied to our data. And we could report loss to follow-up at 24 months as low as 21% at the bottom, or as high as 85% at the top, just depending upon which definition we used. So what that indicated to us is there was chaos in the literature. And people are talking about loss to follow-up rates, and they can't compare their rates with other programs because people are using different definitions. And so there was a flurry of suggestions for a universal loss to follow-up strategy. And I do think that people are making more efforts at the present time, but it's still somewhat chaotic in the literature. So this is an example of a methodologic opportunity within the implementation science arena, where just because you happen to be at the right you have the right database and you have the right insights, you can actually make methodologic discovery, if you will, about what needs to be done definitionally. Now, these are the trials that we're looking at universal test and treat. Can we radically expand the 95, 95, 95, the number of people who know their status, the number of people linked to care, the number of people who are suppressed with their viral loads? Can we radically expand this and thereby reduce transmission at a community level? So there were 4 very large studies that were community randomized trials. But the reason I present this in an implementation science talk is that when you really look at the trials, it really had to do with whether or not you could implement appropriately. And so sure, they were community randomized trials, but in many ways, they were quintessential implementation trials. And where you had very poor implementation, as with the TASP trial, where there were 90% coverage for testing, but only 40% success in referral to care, you saw no community incidence impact. With the search study from Kenya and Uganda, you saw a small, not significant impact. For one of the arms of the HPTN 071 pop art study, you didn't see much impact, but the other arm, you saw a significant impact. In the Botswana study, you saw a significant impact. So on balance, we think that it is a good thing to expand coverage and reduce people's infectiousness, but it was tough to actually implement this to see what the maximum effect would be. The 4th example is prevention of mother-child transmission. And we were noticing how user-unfriendly our program in Nigeria was. So under the leadership of Mukhtar Alahue, who is now the director of the Vanderbilt Institute for Global Health, we had an integrated package of services that we did in a simple community randomized study, where we took mothers and infant clinic appointments on the same day in the same clinic. Previously, they were being seen on different days in different clinics. We integrated CD4 testing in all of the clinics where ART was being provided. Previously, women had to go to a different clinic to get their CD4 and then come for their ART. We recognized how beleaguered nurses were, and we did some task shifting from the nurses to the community health workers. And we did the male engagement that I talked to you about before in community outreach. And as you can see, this bundled package reduced HIV rates in infants by about 3/4 in the bundled intervention arm compared to the control arm. So by implementation science evaluation of how user-friendly the system was, we were then able to design this randomized clinical trial. The 5th example is not HIV, but I just wanted to mention it to you. We did a randomized controlled trial of mother-child pairs enrolled for diphtheria, tetanus, pertussis, the very first dose, in 6 rural vaccine clinics in Pakistan. And we randomized into 4 groups. The standard care group, how many of them completed the DPT number 3, 39%. We redesigned the card to make it much easier, both for mothers and for providers to use. We had a center-based educational group, and then we had the redesigned card and the combined and the education, and all three of these interventions substantially increased by 50 to 70% the coverage for DPT-3. So this was more of a public health trial. Implementation science was the next step. How to bring this solution of the redesigned cards and the educational efforts to scale. A sixth example is one from work that I did with my Chinese collaborators in the China CDC, headed by Ailing Wang. And the WHO, over a decade ago, has recommended that prevention of mother-child transmission programs in antenatal clinics highlight HIV and syphilis and HPV, because we can intervene in all three of them. And I'm kind of out of time, so I'm going to just say briefly, we sought a radical expansion of this program in 1,100 counties in China, where free of charge, all three tests were offered. And of course, the mothers said yes to all three. Why not? They were trying to protect their children. So overwhelming agreement by the moms. And of course, literacy rates are very high in China. And the baseline statistics were 8% of maternal child transmission of HIV, 61 per 100,000 live births of congenital syphilis, and 7% of the mothers were infected. And so we were able to substantially improve that in a 4 to 5 year period. We doubled the number of counties being covered. We increased the number of women being covered by threefold to 13 million. We were able to radically increase the number of women being tested for HIV, the number of women being diagnosed with HIV, the number of children acquiring HIV from the mothers. The percentage dropped even as the numbers rose. And then looking at women being tested for syphilis, being tested for hepatitis B, and then the proportion receiving hepatitis B immunoglobulin, which was 98%. So we were able to achieve in China precisely what the WHO was recommending, which was the integration of these three diseases for prevention of mother-child transmission. And finally, I thought I'd just give you a comment about my own country. Sheila and Rick and I are all from the United States, and this is the wealthiest nation on the planet, with ART and PrEP widely available. Ryan White is the nickname for the law that makes it available, HIV services available for persons living with HIV, and other programs from the Health Resources Services Administration, part of the U.S. Public Health Service, are available for prevention and PrEP. But we have U.S. populations that routinely are being reported with 70, 60, 70 coverage rates. And PrEP is rare in many venues. So two African countries, Eswatini and Botswana, have already achieved their 95, 95, 95 goals. Although I have to admit, PrEP are still rare in those countries. And so if two exceedingly resource limited countries in Africa can achieve these goals, why is my country not doing it? So there's tremendous interest in implementation science in the US among men who have sex with men, particularly those who are Black or Hispanic, which have somewhat higher rates than whites, women at risk, including trans women, at-risk heterosexual men of color, white MSMs who still have high rates of transmission, and we still have some transmission persons who inject drugs. And there is now an Ending the HIV Epidemic initiative in the United States, and various implementation science projects focused on these zones. And I'm working very closely with something called the HIV Implementation Science Coordination Initiative, which is trying to promulgate this around the United States. So by no means is this implementation science agenda in HIV something for the world's poorest countries. The world's richest countries need this work as well. STI control is a great example where we've had a resurgence of STIs in past decades in the United States, including a major return of congenital syphilis. And we wrote a paper in Sexually Transmitted Diseases that summarizes this National Academies report that I chaired a year ago. So the conclusion: we want to innovate through discovery and efficacy, but we then want to see our contributions make a societal impact. And we're not going to get to the societal impact part if we don't do implementation science, because we're seeking real world effectiveness and scale up. And we want to reduce the 17 years from efficacy to implementation. I'll try to drop in the chat this Zoe Morris article from the Journal of the Royal Society of Medicine, published about 12 years ago, where the answer is 17 years. What is the question? Understanding time lags in translational research, because she did a deep dive and found that from discovery of efficacy to actual implementation was an average 17 years. And even then, you were only penetrating about 14% at that time. So with excellent IS research and partnerships, we can reach this, but we're going to need to work with hospitals and health systems, public health departments in the United States, federally qualified health centers. We have to work with social behavioral sciences, scientists, policy experts, communities, policymakers, and advocates. So thank you for your attention, and I look forward to questions.
Thank you so much, Prof. Stein. It was fascinating. The floor is open for question and answer. You can use your microphone, or you can write your question in the chat box. And just to let you know, Prof. Stein is a wonderful person. So please don't miss this opportunity to learn more and more from Prof. Berman.
You're too kind.
I'm humbled, Prof, to have you today among us.
Well, I'm here for the whole week, thanks to the University of Malaya making it possible for me to serve as a visiting professor. So I'm enjoying my full week. This is only my second day on the job. I see it. I don't know if that's a hand. Oh, that's my hand. Never mind. Any questions, comments? Does any of this resonate with some of the challenges you find here in Malaysia? Maybe somebody wants to give us an implementation science challenge where we know what to do, but we're not doing a particular job expanding it to the scale that we need to make a public health impact. Are there any examples you want to bring up? Hello, my student. So
Hi.
nice to see you.
Hi, Professor Berman. It's so
Dr.
nice to see you.
Janadun took my course last term, long distance. I think she got up at like 4:30 in the morning to participate.
Yeah, it's so nice to see you again.
Thank you.
And thank you for your talk. It's really interesting. I think my question is just a curious question with regards to your example, your study in Pakistan, the vaccine study, and it's an RCT with 3 different groups. So I'm just wondering what was the subsequent study, the implementation science study to get the clinics to the hospitals to actually adopt either the redesigned or modified card, or the what's the other one? Educational program.
That is such a great question. This was one of the regrets of my professional career. What we did in this case was we took our card and offered to the Ministry of Health, and we explained the results of our study, and we relied on the ministry to expand the maternal education and the use of the cards. And there was a transient blip where some of these cards were being used and distributed, and some of the clinics were being exploited. But when we went back to see the extent to which this was successful, we saw that the implementation had not been nearly as successful as it should have been. So this is where I did the public health science, and I did the with my Pakistani colleagues. We did the dissemination to the key stakeholders, but we did not do formal implementation science. And because of that, I believe that the influence of our intervention was far less than it should have been. So that is not a happy implementation science story. I think many of the stories I told about PMTCT and ART expansion in Africa have a happy ending to them. This one, not so much. That's why we need implementation science. You cannot simply, we used to say, do your public health study and then disseminate the information. Then you can go back to your office at the university or the hospital and do something new. It's not that simple. When you don't persist in the implementation science elements, there's a very good chance that your innovation will be lost in the mists.
Thank you, Prof. Verman. I really like the example about reaching out to the community as well and getting the community involved. Like the example you gave just now was to reach out to the local theater and have them sort of have the community. What the community is probably more interested in is to get information through probably their local theater rather than using media when it's not effective. Yeah, thank you.
That was the cultural norm in urban Zambia in the early 2000s. The cultural norm was they're not going to read a poster. They're not necessarily going to pay attention to the ads on the radio. They would there would be a lot of word of mouth if you did the street theater, for which there was a very strong tradition. And you know, the first time I hired this group, I was a little nervous. I did it because my Zambian colleagues told me that would be effective, but I didn't know what was going to happen. So I went to one of the presentations, and I could kind of guess what was going on based on some of the body language and all the rest. But I had my colleague who spoke Nyanja, the local language, translate for me. And I was amazed at how accurate the public health messaging was from this street theater group. They really understood the science. They really understood the attitudes in the community that would obstruct people from agreeing to testing and agreeing to care. And they were crafting a level of creative artistry that I could never imagine in a million years from my own background. So you're absolutely right, Graziel. The use of culturally appropriate, locally vetted communication strategies can make all the difference in the world. You remember the male champions, having other men in the community talk to men. That was the only thing the men were going to listen to. Sadly, they weren't listening to their wives or the healthcare providers, but they would listen to other men whom they respected. So you have to find what are the cultural approaches. And here in Malaysia, you have Malay communities, you have Indian communities, you have Chinese communities, you have other ethnic groups in Sabah and Sarawak. You have tremendous diversity. And it may be that what works in one community needs to be redone in a different community because there may be some different sociocultural norms and different traditions. So it's especially complex for you to figure this out.
Thank you, Prof. Verman.
All right, very good. Thank you. Maybe we'll move on to the next speaker.
Thank you so much, Prof. Stein. And Graziel, thank you very much for the very interesting question that you raised. For me, the biggest takeaway message from Prof. Stein's presentation is building the connection with the community and user-friendly strategies. I think these two can do magic. Thank you very much, Prof. And I wish we could hear from you forever and ever on implementation science, HIV, and all of your research work. Thank you so much. Our next speaker is Professor Frederick Altis, and I'm very pleased to welcome Professor Altis in today's webinar. We all know Professor Altis, a professor of medicine, epidemiology, and public health at Yale University, School of Medicine and School of Public Health. Prof. Altis has been working in Malaysia since 2007. So we always tell that Malaysia is Prof. Altis's second home. And for us who have been working with Prof. Frederick Altis, creativity and innovation, these are the two words that are synonymous with Prof. Altis. Without any further delay, I would like to open the floor for Prof. Altis, and please join me in warmly welcoming Prof. Altis. Thank you.
Romana, thank you for that lovely introduction, and Rasta for co-sponsoring this talk. I also want to send a note. I don't know if there was any introduction earlier, but Prof. Adiba could not be here today because her mother passed away last night. And so I also want to say that she wished that she could be here. And of course, we all understand why she cannot. And I want to wish Prof. Adiba and her family well as they're going through this very challenging time. So anyway, it's always a pleasure to be here. I will clarify that I've actually been coming since 2005. And even though you introduced me as Prof. Frederick, I don't think anyone knows me by that name. I typically go by Prof. Rick, but indeed, my given name is Frederick. And one of the things that I've been asked to do is to really talk through facilitating behavioral change through motivational interviewing. And the genesis of this was to really maybe perhaps give a guide for clinical practitioners in order to make changes within their clinical setting. But I will end by sort of focusing on how a lot of motivational interviewing is related to implementation science. So what I hope to go through in the next 45 minutes is to define and operationalize motivational interviewing, review some of the principles and the guidance for this, move it into a real-world practical use that we can use in clinical practice. It's the sort of thing that I try to do when I'm teaching the medical students on how to do motivational interviewing in their clinical practice. And then to sort of just end with one brief slide about how and why motivational interviewing has its place in implementation science. So just as a definition, it is considered to be an effective way of talking with individuals about the work of change. And I purposefully use the word work because it is work. It's an active process of going through change. And then just to give you a little bit of background is that MI, or motivational interviewing, is an evidence-based practice with over 1,200 publications supporting its efficacy. And, this all sort of evolved in the early 90s when Miller and Rolnick wrote their book on motivational interviewing. And it was actually geared for changing processes in individuals around substance use disorders. And of course, it's been expanded to an array of things, including what you do in clinical practice. Now, there are 4 key principles, and I will say that this first section of the presentation is really just to sort of make sure that we hit the underpinnings of motivational interviewing. And, a lot of this stuff just makes sense. And I will say that from a practical perspective, as a parent with 9-year-old twins, I use a lot of this in trying to work with them to modify or change their behaviors. And you'll recognize some of this as you go through this. I think that there is, on one hand, the iron fist approach with children. I think that that's probably good when they're teenagers or, very, very small children, where you have to set limits. And then later on, as they evolve and become, move into adulthood, we have to really think the way that we engage with and interact with them. And that is indeed the case that for what we do in our clinical practice. And I will say, as in implementation science, as we think about process changes at the structural level, systems, clinics, and with one-on-one with patients. So one of the first key principles is to express empathy. And part of the reason for doing that, and I'll give you some practical approaches, is to really build rapport. If you walk into a clinical setting and say you haven't been taking your medications, there's no rapport there. You're just sort of telling them what you observed without sort of building a rapport so that they feel comfortable having a conversation about why it is perhaps that they aren't taking their medications. The other sort of part of this is to roll with the resistance. I call it putting up the hand. When we go in without building any sort of empathy or rapport, there's an automatic block that happens where they're no longer listening. I've heard parents with children who were slightly older than mine where they just don't listen anymore. And that's because there's resistance in the conversation because it's not balanced and two-sided. And so it's important to respect the client's autonomy, recognizing that they are full-fledged individuals who can, and when they are ready, will make changes. It's also important to really develop discrepancy. And part of that is when somebody says, this is what I want to do, but the ways in which they're going about it perhaps don't really sort of align with that sort of stated goal. And that's where you have to go back and do some clarification. So one of the ways of doing that is to elicit the pros and cons, perhaps, of changing a behavior. Let's say, for instance, taking your medication as prescribed, or taking your PrEP as prescribed, or any of these sorts of things. And so to really identify what the person's stated goals are and what their current behavior is. And it is probably going to be a process of activities that have to happen before it's changed, instead of just saying, well, just take it every day, put the medication by your toothbrush, and you fixed it. It doesn't really work quite that easily. Of course, it does for a few people, but not for the overwhelming majority of individuals. And then, of course, the other part of it is to support self-efficacy. And, the idea that you communicate that the person is capable of making change. They've made change in other areas of their life. So sometimes identifying that, oh, I was able to do this in order to achieve this. So pointing to those other areas where they have been able to make change, even though perhaps at this time point, they don't feel like that they're capable of doing that. One of the key elements of motivational interviewing is listening rather than telling. And Carl Rogers really got this just right. I'll give you a couple of quotes. They're all here. And of course, I will make sure that Romana makes the slides available to you. But he said, we think we listen, but very rarely do we listen with real understanding. That is true empathy. Yet listening of this very special kind is one of the most potent forces for change that I know. And part of that is that we will sometimes hear things, but we're not really understanding. And so we have to ask clarifying questions in order to make sure that what the person said, was it what the person meant? And what they meant, is it what I understand? And then reflecting back to the individual with, this is what I understood you to say when you said this. And they can say, well, maybe perhaps that's not really exactly what I meant to say, but you're getting close. And then you can have that sort of conversation around clarification that can occur. The other thing that's important to recognize is that there's not just a quick fix to this. And I think that, with some of the examples that Sten spoke about in his presentation around, change, you come up with an evidence-based practice based upon a clinical trial, let's say in Pakistan. But, these changes are neither quick nor easy, and they may be very different from community to community. So it's really important to clarify what the changes are that we're talking about, and that, and this is a way to actually sort of garner support, is to look at some of the other decisions that require change in people's lives, what they've succeeded with and what they've overcome and how they did it. and to sort of point to those, to sort of award them, to really acknowledge those sorts of things that they've been able to do, so that they can look at changes in one part of their life potentially having some implications for how they change other things in their life. Some of the basic premises for motivational interviewing. There's a lot of acronyms, I will say, in MI, another acronym. This one's called RULE, and I don't always put them in this order, but if I change the order of these of the elements of the acronym, it wouldn't spell a word that we would understand. So the first one is to resist telling them what to do. In other words, your viral load is still detectable. You must take your medications as prescribed. That is one of the things that we do not do. So you avoid telling them or directing them or convincing them about the right path to better health, because that becomes unidimensional. It is an imbalance of power, and it does not really acknowledge the fact that they are equal partners in this change project. So no matter what you tell them, unless that they agree to the fact that it's important and that they have the confidence to actually make the changes that are needed, nothing's going to happen. The second part of this is to understand their motivation. And, people come to the table with their own set of values, needs, abilities, and motivations, or barriers to changing their behavior. Now, this may not be a person that you all know, but Ray Charles was a famous American singer, just absolutely wonderful. And he spent probably 50 or 60 of his years injecting heroin. And, it was interesting when people said, why don't you quit? He said, you have a problem with your heroin addiction. Why don't you fix that? And his response, which was interesting in terms of understanding his motivation, and this is actually when he came into the hospital because he was withdrawing, and he said, I don't really have a heroin problem. I have a drug dealer problem, because the reason why he was in withdrawal was that his regular dealer who was providing him with the drugs did not show up. So he didn't really see this as a problem. So his motivation was not to feel sick, which was very different than it's my motivation to stop using drugs, because he saw them as two very different sort of scenarios. Now, many of us, of course, who take care of and work with people who inject drugs, there are all kinds of other factors that get in the way, such as access to money and other sorts of things that play a very different role. So it's important to seek and understand their values. In Ray Charles's case, he didn't have any interest in stopping to use heroin, but he did have an interest in making sure that he had a regular dealer who was able to sort of help him through that process. Of course, if the dealer were to repeatedly not show up with the goods, then he has a real problem. And then maybe perhaps there might be sort of a kernel of readiness to be able to make change. There's also the listen with empathy element, and that is to really hear their perspective. Why is it that this is your value? What are your needs and stuff like that? And it's very much related to understanding their motivation, but to really listen, that sort of reflective listening, to make sure that you understood what they said. It's oftentimes the case that people will say one thing, they mean something different. So that's when there's conflict resolution that you have to explore. And then what you actually heard, which may not be exactly what they either said or meant, and then to understand what it was with their goal. So that is really the important part of reflective listening, to reflect back on what you hear and what you understand or what they understand. And then lastly, to empower our clients to really set achievable goals and identify techniques to overcome barriers. So in other words, if a person is smoking cigarettes and you sort of say, oh, your goal is to stop smoking cigarettes, but doing that tomorrow, given the sort of the biology of nicotine receptors and experiencing really awful withdrawal, it may not be achievable just to say, okay, I'm ready to stop, and then just stop. Of course, we've all heard examples of people who make a decision to stop and they do it the next day and they succeed, but those are few and far between in clinical practice. Part of the reason why we use the motivational interviewing is because the kinds of things that we will actually say and interact with our client with really is going to be, based upon where they are. And we'll use tobacco as, an example. And I can pull from my own family from time to time with some of this. And so there's pre-contemplation where the client, or in this case, my family member, had absolutely no intention of either stopping or, reducing. And so having a conversation with, you must stop this or else you're going to get cancer, they don't really sort of hear that. So it may require multiple sorts of, statements around what's going on. Well, gosh, Mom, we don't have enough money to pay for food. If we weren't spending money on cigarettes, might we be able to sort of, eat, 3 proper meals? And so those are the small little nudges that can happen to move people from pre-contemplation to contemplation, which is they're aware that there's a problem. Gosh, I am smoking. It's costing me, a fortune to pay for cigarettes, and it's really getting in the way of the food, but I don't really know how to do it. There's not a real commitment. There's this sort of, they're just the recognition that there's a challenge there. And then, of course, we go through this motivational interviewing process to move people to the next step in this continuum, which is preparation, which is where they say, okay, I'm ready to make a change. And this is the place where we're actually able to do a lot more, because they're ready to start making steps to really engage in a sort of a multiple pronged plan to overcome that. And then, of course, there's action where they actually do the things that you all agree upon in a stepwise fashion to change their behavior. And then, of course, getting them to maintenance, that is sustaining change. And it's sort of interesting. This is what happens with implementation science as well, as we're sort of going through the whole process and trying to make the way that we do the things that we do that are evidence-based well. And then just sort of recognize that this is a cycle, but the cycle sometimes backslides, and that people actually go in reverse for some time period. And it's important then to go back and recognize where they are in order to move this. So the other thing is that that change is typically hard. Whether you happen to be the dean of a school of public health and you're trying to get your faculty to change the way that they do things, or whether you're trying to get your kids to make changes, it's typically hard. People like to do what they're doing, and you get the kinds of results that you get when you don't make any of these changes. But it's not always because an individual has a lack of information. So we should not presume that because a person's not taking their medications, that it is a lack of information. It could be, but we shouldn't presume that. Or that the person is lazy, they're unwilling to make any sort of changes, or they're just in denial that there's a problem. I think clinicians often use these kinds of terms. It's a labeling process that is really negative, and it doesn't actually help us sort of move patients along. My sort of approach is, boy, this is hard stuff, and let's work on it. Let's chip it away at it one thing at a time, and let's see where we go with that, and then to sort of go through that. So what we're really talking about for most of patients who are really struggling with the issue of making change is an ambivalence. And that is, if their behavior, let's say, is smoking cigarettes, it's their ambivalence with sort of making the change that may or may not, at least in their perception, improve their health. And what are the trade-offs with regard to that? I'm going to gain weight, or I'm going to eat everything in the kitchen sink, or I'm going to experience psychological withdrawal. And so there is oftentimes this ambivalence of wanting the change and not wanting it, because the trade-offs sometimes, at least on the surface, appear important. And so that's where you sort of walk through the process. All right, what will it take to make this change, and what are the costs to you in terms of doing so? I think that there's a fair amount of, excuse me, I missed my slides moving, is that, that there is the perception that when there is ambivalence, that it leads to, procrastination. And it's often viewed as resistance. And that's just because the trade-offs, at least at this particular time period, don't seem in the right balance for the individual. And so it requires sort of chronicling those and sort of laying them out to see what a person's values are, around, let's say, going through withdrawal or gaining weight. I mean, all of those things may be of different value to each individual. So in motivational interviewing, we try to revert from using the words of unmotivated or the person being resistant, because it's not our goal really to get our patients to yield to our advice. That's one of the reasons why in the adherence literature, we talk about adherence rather than compliance. In other words, getting our patients to comply is really sort of pointing out an unequal dynamic, but instead to really guide them through the decision-making process step by step, because small changes are a lot easier than the big changes that often happen. So the 4 concepts in the spirit of motivational interviewing are partnership, acceptance, and evocation. I tried not to put an acronym, but it's called PACE. And it's not surprising that our partnerships are that we work together and avoid the role of the expert. Now, at least in terms of clinical, practices, medication A versus B, we often are the experts, but it's important for us to sort of let them know that these are the options. They are the experts on them. We are the experts on the medicine. So we have to sort of acknowledge that there are 2 experts at the table. And so even just stating, I value you and I'm delighted to work with you in this whole process of making changes that you agree to. And then the acceptance part is to respect the client's autonomy and their strengths and their hopes, and that our patients come to us with a fair amount of strengths that we may not recognize. Let's say they may not be taking their medications properly, but indeed they've made other sorts of successes like working 2 jobs while they're raising their family. And so that's a really important part to sort of recognize these other parts of a person's life where they have had successes and to build upon that. The compassion is keeping the client's best interest in mind. It's oftentimes that we will say, well, if you don't want to die from HIV, you take your medications, but sort of really understand that there are maybe perhaps other competing priorities that are getting in the way. So bringing that compassion and, even just asking the questions. So in your opinion, what do you think is getting in the way of taking the medications? Of course, they might say, I just don't really think I need them. Or it could be something as, I'm just too afraid to have someone see my medications, which happens in a number of different settings. And then, of course, evocation is to really sort of evoke and get the patient to really identify what sorts of ideas might be workable for them. So for instance, once again, with adherence, we might say, we'll put it next to the toothbrush, but nobody in the household knows. And so, say, how do you hide other things in your life, that you want to sort of, keep other people from knowing, or have you, had any conversations about disclosing this to perhaps other people? And then you understand their values and their own in-depth barriers that they have in bringing their challenges to the table. So there are 4 major skills that we're going to try to get through. That is using open-ended questions, providing affirmations, that is successes, reflecting back on what you hear and what they say, and then to summarize to make sure that there is clarification throughout the process. So some of the potential open questions, let's say that you don't want to know, is it may be that your sort of idea, you sort of like do an audit test for alcohol use disorder, and they're structured questions. How much alcohol do you drink every day? Which is laden with a fair amount of sort of expectations that they're not doing well, or are you not taking your pills like you're supposed to because their viral load is still elevated? The answer is yes to many of these things, but the way that you ask the question can make a difference. Words matter. So you could translate that first question into, what role does alcohol play in your life? And, let's be perfectly frank, for many people, alcohol gives them pleasure. 1 drink gives them pleasure, 2 drinks gives them more pleasure, 3 drinks may make them sick. So, just sort of what role does it play and how? And then in the case of pill taking, you could start out by just acknowledging that taking pills is hard because, that their viral load is not suppressed, and state something like, it must be challenging to take your pills every day as recommended. What kinds of challenges have you been encountering in being able to sort of meet this goal? Or even just asking, is it a goal to take your medications every day? And, and I remember by asking this in the past, people would say, well, I don't want to take it every day because if I take it every day, I might have more side effects and, more might hurt me. And then it required going back and exploring some of the information deficits in that setting. With regard to the affirmations that we give patients, they're essentially words of encouragement, as opposed to, well, you failed to do this and you haven't done that. you're really sort of setting the language with regard to awards, the fact that they have attempted something, even though it may be hard. They've had achievements in, let's say, other parts of their life, or they've had many achievements and now they've just sort of backslid a little bit. And now you sort of need to build them back up in order to get them back, through that process of change, and to sort of really recognize openly their accomplishments. And I just say, start anywhere where you see something positive about the client. Every single person we know has something positive about them, and to sort of acknowledge that. So here's a couple of examples that I sort of just put together. This is from work that we do in addiction treatment. But given that your urine test was positive, it must have taken a lot of courage for you to come into your appointment, recognizing that they may feel guilty, or if they come in high or something like that, that they really, it was a big deal for them to cross over that threshold and to come into appointment where they might at least feel judged. We often use the word stigma, but it's really judgment that they're very concerned about. They may not be doing so well with taking their pills, or as well as they would maybe perhaps like to be. You seem to care a lot about making sure your family is okay, let's say by working or having money or putting food on the table. That is a positive thing. And, then you could begin to go down that pathway of, well, gosh, you're doing this really well. What do you anticipate being able to do in terms of, if you're not taking your medications and you get sick, who will put up, food on the table? Have you thought about, who might be your backup plan in order to sort of help them balance the pros and the cons of making that decision? And then another sort of way is it really seems like you have a lot on your plate, and yet you still made it to see me today. So these are all positive things, because one of the things that is that person went to the effort in order to see you, and you can always rely on that as your minimum amount of positive input into that conversation. Now, I use this sort of photograph as a way to really think about it. I think we can all look at this and we see that there is a person who is doing a yoga position and looking for peace. But, there's the reality on, the one hand, which is them standing on the beach. And then there's the reflection into either a lake or the ocean of the inverted thing. And we both recognize this, but it's really sort of making sure that we understand what we're seeing. Are we seeing the person in reflection, or are we seeing them as they are? So part of this is understanding what the client is thinking and feeling and saying it back to them. One of the ways of doing that is, for instance, if they say, I've been taking my medications most of the time, and you can certainly say, oh, so I understand you're taking your medications, most of the time. What does that mean to you in terms of taking them? Well, I take them Monday through Friday, but I just can't get to them the weekend. And then say, oh, so the weekends seem to be a problem. And they can say, well, yes, sometimes, but other times it's the weekdays. Then you go into their schedule. So it's really about reflecting on what they say and letting them sort of come back to you with what they mean by that. And then always when they say what they mean, you clarifying what you heard and what you understand. And what these reflections allow the clinician to do is to convey, one, empathy, that they're listening and they're understanding, to see the world through the clients. Because once you go through that reflective listening process, you will get at true understanding based upon what the person said and what you eventually understood. Because oftentimes there is a disconnect when we jump to the conclusion, oh, I'm really not taking my medications well, for example. And then you make the assumption, oh, well, you don't really care about yourself because you're not taking your medicines. That's not really an understanding of getting them to sort of help you understand the process that they're going through. And then the last part of this is to really provide summaries. From what I heard you say, I understand X. And if I'm understanding this correctly, that means Y. And then sort of just saying, now, just to clarify, that means your goal is, and let's say, for instance, with, let's say, drinking, your goal might be that you want them to stop drinking completely. And their goal may be, well, I'd like to not be impaired. So I'd like to not get drunk, but I don't really want to give up my alcohol. that becomes a place where change is, where there's a difference in terms of the goals, but using their goals as the way in order to get them to make that change, because that change can perhaps over time result in another level of change. And, so I think that it's really important to help them set the goals, reinforce that, that the client is motivated to change. Remember, if they're in the pre-contemplation stage, they may not be in that place. And so you can sort of just work at things like, what would you need to know in order to make a change, for example, to highlight their realizations about what their understanding of what things are, and to identify some transitions and progresses and themes that have gone on during the course. Because, when we have relationships with our patients with, chronic diseases, we're going to be seeing them repeatedly. And so we can reflect on an array of things. And, the idea that the first time you see a person, you're going to get that change is going to happen is not going to be the case. And so I would sort of look at that. The processes that we often use are to engage them, to focus them on the goal, even though there may be other sorts of things going on, once again, to evoke their ideas and to make a plan, and to sort of, and I'll talk a little bit about what that plan needs to be, because it cannot be too ambitious such that the person can't do it. So with the first step is engaging, making them feel welcome. The reflective listening helps a lot. Making them feel comfortable. Oh, I'm so glad you made it to your appointment, even though you've been having such a tough time. Making sure that when you ask those clarifications, that they feel understood. Making sure that the goals are similar. For instance, where there is a disconnect, recognize their goals and say, gosh, wouldn't that be a good step towards moving towards X, Y, or Z? But let's focus on your goals first. And then being hopeful. That is, believing that the person can make that change. It's so often that, I've been with seasoned clinicians and they said, they're just not motivated. They can't change. And that's just not true. It may be true that they can't change today, but that doesn't mean that through, continued engagement that they can't change over time. What we really need to do is to avoid things that make it disengaging, that is, make them not want to come back for an appointment. So one of the things that we do is avoid assessing. You aren't taking your medications right. You need to take your medications better. You are a non-adherent patient. You are a patient who does not do what's good for them. Those are labeling. Those are all the things that we really want to avoid. It's interesting in implementation science, that's also the same tactic that I have, is that I sort of don't tell them that they're doing a bad job. I sort of capitalize on the things that they're doing well and try to help them see that as the next step. The other thing that is really important, and I think that this has been transformational in medicine, even from the time when I trained, 35 years ago, is to avoid these power imbalances. The idea that the clinician is the king and that these are your subjects. There are these power imbalances. And I sort of love to sort of revert to the Sylvester and Tweety cartoon, because we see this as what appears to be a major power imbalance, with little Tweety in their little cage locked away, and Sylvester having complete control of everything. But invariably, Tweety Bird always prevails, because Tweety has their own ideas about what they can and will do, and it's important to recognize that. We also need to avoid that the perception that clients are unable to change, that they are impaired and they're unable to understand the situation. Asking clarifications, what is it that you understand, is a helpful way to do that. There's also this idea that a client is assumed to lack capacity. They won't change, they can't change, they don't have the skill sets to change or to self-direct, and that we need to avoid really telling the client what he or she must or should do because it's better for them. Remember, the client is also the expert. I love this quote from Maya Angelou, who was the poet laureate for the US. And she made this statement: I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And so how you make them feel in that clinical encounter is absolutely crucial. If you're doing implementation science and you're working with the government, saying you're doing a terrible job at reaching your 90-90 targets or 90-90-90 targets is not going to make them feel good. You know, to say, oh, you've really overcome a lot of obstacles, you've gotten this. What do you see as your sort of next goal? Hopefully it'll be the 95 targets. And how do you think you might be able to get there? And so, it's really about making sure that people don't feel undervalued. And in that clinician encounter, that's a really important way because they don't come back. And that's why we've got such high levels of dropout from care for HIV, but also for many other diseases. They don't feel valued. They don't feel part of that. And we sort of just need to recognize that patients may not have had the kinds of successes that we'd like them to have, but nonetheless, they do have successes along the way. And then, of course, the other thing that we do is as we're understanding all of their values and other activities that are going on in their life, it's always important to redirect and to focus. So it is an ongoing process of maintaining our direction. What is it that you truly want to change? The person says, I don't really want to stop drinking. As I said before, I don't want to quit smoking, but I'd like to smoke a half a pack instead of 2 packs a day. That becomes a place to start. That is a change. It may not be the change that you think that they need, but it is a change. I take my medicines Monday through Friday, but I can't get Saturday and Sunday. Gosh, what would you like to do? Well, if I could get one more day a week in there, that might be the thing to do. So once you go through that process and you identify what it is that the person wants to change, I want to reduce my cigarette smoking from 2 packs to a half a pack a day, agree on that goal, set an agenda. How are you going to get there? And setting the goals and the priorities to create a clear direction. And these goals have got to be attainable. And I'm going to spend a little bit of time going through a list of goal setting in terms of what it might look like. And then, of course, the last part is evoking. Really try to understand what the client's own motivation. I want to reduce smoking from 20 cigarettes a day to 5 because I know that that's going to cost me 1/4 of the money. Well, you might say, well, what about your health? Well, that may not be where they are. It may be that they want to, have more money in their pocket to put food on the table or something like that. Or, gosh, I just don't feel like that I'll have bronchitis quite as often if I can just get down to a smaller number of cigarettes a day. Really, you need to have discussions that favor movement in the direction of change. That might be reduction in cigarettes that are smoked by sort of understanding what it is that they want, what they wish for, my reasons for wanting to reduce from 2 packs to a half a pack a day are X, Y, or Z. And if I did this, it would solve, let's say, my financial problems. Well, it may solve them partially, but not all of that. So, but you have to have a place to start. And then, of course, the planning process really is about having specific changes. And I use the word changes as opposed to a change because change in general is a process. It's not an event. It's not, okay, I stopped smoking my cigarettes. As I pointed out earlier, there is the handful of 5 or 10% of people who have this life-changing event. They got intubated and they can stop the next day. But that's not how it is for most people. It's a process. It's a series of small incremental changes that require you to assess that and to achieve each goal step by step. And remember that when you have a success with one goal, it increases the likelihood that you're going to have successes in your other goal. One of the things that I do is I make an agreement. I used to actually write out a prescription. Our goal is this is before the electronic medical record, but I would write out, our goal is that you're going to take medication 6 days instead of 7 days. Let's do it. And let's see each other in a month and let's see how well we do with that. And then you can go from 6 to 7, with that next one. Part of creating these goals is having a smart plan. You be very specific. I want to go from 2 packs a day or 20 cigarettes a day to 5 cigarettes a day in 4 weeks, for example. So it needs to be specific. You need to be able to measure it. So in other words, if they say, okay, my goal is I'm going to try to quit smoking, There is nothing smart about that. So it needs to be measurable. And is that goal attainable? People don't just all of a sudden make a quick change. So I like to know that it is going to be attainable. It's realistic for that individual based upon their other abilities in life to achieve change. And is it timely? What is the time period? So this I will try to quit smoking might actually be reframed as starting on Monday. So you have a start date. I will cut back on 1 cigarette per day every week until I get down to 0 or to 5 or whatever it takes. So you have X number of weeks that it's going to take. That would be 20-week plan in order to do that. And then you say, okay, great. I will see you in 4 weeks and see if you have gone from 20 to 16 so that we can see what's worked well for you, what hasn't worked well, and what is the next thing that you're going to try. One of the things that from a clinical perspective is I always recognize that my agenda may look very different than my patient's agenda. And so there is a disconnect in terms of where they are. And that's where the reflective listening makes a difference. And so we do that by providing some advice, some negotiation, have you considered this, and some counseling in order to make these changes. There are probably more than this, but these are the 8 unhelpful assumptions that I can think about that you really should not do. And that is that the patient ought to change their behavior. They have to be ready and want to, or that they come in and they want to change their behavior. And so you can say, gosh, what would you like to do? And they say, well, I want to reduce my cigarette smoking. And then, but you need to clarify to make sure that that really is what they want to do, that the patient's health is the primary motivator. Our patients come from all places in life, and many of them are just dealing with an array of other things such that their health may not be the number one priority. But as clinicians, that's our sort of lens that we see things through. If the person doesn't choose to change, that they're in the pre-contemplation or even just barely the contemplation change, that our intervention for our work has failed. No, we just sort of keep checking in. Has anything changed in your life? Have you thought about this? Just that prompting might be enough to move them so that your next appointment in 4 weeks or 3 months is a place where you can come back to that again. Or we should not assume that our patients are not motivated or that now is the right time to choose to change. If they're pre-contemplative, now is not the right time. It's really about sort of just helping them understand information and perhaps motivation deficits. People often perceive that a tough approach is the right approach. You better get it right. And then, of course, that issue around imbalances in respecting patients' autonomy. I'm going to try to really cut this down into a couple of things that I think are much more streamlined. So once again, establish the rapport, explore the pros and the cons, help with the discussion, summarize, and help set the goals that are as part of that SMART plan. Let's see if I can move to this. So here's my quick assessment, and it may even be less than 5 minutes. And so I try to make it as simple as possible. And this is not part of Milner and Rolnick's part, but it's how I operationalize it in a clinical setting because I have a limited amount of time. And then, so for instance, the question might be, how important is it for you to, they say their goal is to reduce cigarettes. How important is it for you to, reduce your smoking? And I do a 10-point scale. And then the second part of that, if it's important, that is their scores an 8, 9, or 10, I move right into how confident are you about changing? And what I do is I do some exploration. If they say it's a 6, so, you gave yourself a 6. What is it that you might need? That's good. That's a start. That's not 0 or that's not 1. Why did you score yourself at that particular level? Then you get the pros and the cons. And then the next part is you want to move them towards an incremental change. That's why I up the score 2 points and say, all right, well, what would you need to know or be ready to do in order to move that from a 6 to, let's say, an 8? And sort of go through that whole process so that there are some incremental changes with that. So here's my sort of 10-point scale. Low, I put it under 4. I put high as 8, 9, or 10, and everything else is a medium. And I don't even focus on confidence if it's not important. So it has to be important first, because then you can come up with a plan. Then, if once you move them towards it being important, this is what I do with the pre-contemplation and the contemplating group, is I sort of try to move that importance score a little bit higher by sort of understanding risks and benefits. And so if their confidence score is high, confidence is on the top, and importance is on the top and confidence is on the left. I don't know, it must have gotten shaded out. But if everything is high, just recommend an action. I'm going to cut down by 1 cigarette per week for the next 20 weeks. So reinforce the skills and that they're going to use in order to get there. If the confidence is low, and if the importance is low, I'm going to educate them on major important information deficits and help guide motivation. I'm going to assess them for depression, any other sorts of things that might get in the way of, I just don't feel like it. Well, that's a sign that there may be, some depression or something like that. If their confidence is low, but it's important, I really try to focus on what are some of the behavioral skills that a person might use. I'm not taking my medications. Have you tried putting it next to, your toothbrush? Have you put it underneath of your pillow? Have you put it in the shoes that you're going to wear tomorrow so you take it first thing in the morning? Those kinds of things. And then, of course, if everything is low, you're really going to have to focus mostly on information deficits and motivation. What's important is that when you are being met with resistance, where you have these conversations, you agree on a plan, and nothing happens, one of the ways that I recognize that and I back off is if they're arguing about it, if they're interrupting you or you're interrupting them as they're speaking, there's a failure to make let's say, at least in substance use, the linkage between, my alcohol use and, let's say, being able to get up from my job the next day. They're not making that link. So to really create those linkages, or if they're ignoring the problems or they're failing to engage, that's when there's resistance, and say, okay, perhaps we're having a challenge. What is it that I can do in order to help you at that point? And sort of give them back the shift. I do this exercise when I'm teaching trainees. If you've ever gone up, next time you're with a colleague, just say, hey, put your hand up, and start pushing their hand away, and they're going to resist right back. And if you can just give way, there's not really a conflict. So I sometimes will shift the focus, talk about something else, express empathy. This has really got to be hard. This is something that you can do whenever you're ready. I'm happy to be able to help you work through some common goals, re-summarize things to make sure you've clarified, and don't provide the solutions. They are the best provider of solutions because they know what has worked. You can suggest things. I've heard from other patients that this works. Do you think that this might work for you? They say, oh, I haven't thought about that. Or, no, I've tried that before. That doesn't work. And as you're exploring the importance scores, what is good, what is bad, where does this leave you now? And then building the confidence is really through things that they've succeeded with in the past. What has been helpful? Oh gosh, you were able to reduce from 20 to 16 or to 10 cigarettes, but you've not been able to move any further. What was really so successful and what got in the way before? So you can sort of work through some of those other successes in order to get there. And I think it's important to remember that because it is a process, when you start meeting with resistance or the person just is not ready to make changes, always leave the door open. So, say, we've talked through this and it seems like, right now you're not, you're not ready to reduce your alcohol use. And then I just sort of like open the door about getting permission. Would it be okay if we spoke about it at your next visit? That way you can sort of say, well, I'm open-minded about it. You're asking for permission. Or if you want to talk about this further, at some stage, you can schedule an earlier appointment. I'm happy to see you a little bit sooner so we can, sort of work through some of these sorts of things. So I'm going to review this. You try to establish and shift rapport. You want to understand what their agenda is relative towards yours. I quickly assess the importance and the patient's confidence so that I can see whether I need to work with information, motivation, or skills deficits. I explore them through that process. What would it take you to move from a 6 to an 8? Gosh, you've done this before. This is what you can maybe perhaps try, or go through that whole process. And then I summarize and identify the next steps. From an implementation science perspective, I use a lot of MI within that. So we aim to improve the processes by which we deliver an evidence-based intervention or practice. So it might be vaccination, or it could be scale up of antiretroviral therapy, or any of these other sorts of things. And remember, the goal for better implementation often requires a number of smaller changes. People love protocols, and I think that protocols are the death of implementation unless you're ready to change them. So ministries of health will often say, this is the protocol, but it's not the final protocol. It's a starting protocol. And people get really sort of jammed up on that by thinking that this is the way that you have to do this. And so we can really overcome a lot of these challenges at whatever level, the system, the clinic, the individual, because people may be resistant or feel unable to change. And so we can use a lot of these skills to go through the process. So bringing it back to implementation science, and this is part of these small changes, set the expectations to reduce cigarette smoking or to scale up ART coverage from 60 to 70%. That is a first goal. And then what you do is you sort of set up some kind of reward that, and it does, and rewards are not always money. They're successes, awards, certificates. We can do all kinds of things that we can do, rewards. I used to have little stars when patients would change a behavior around medication adherence, and I would put it on that prescription pad and give it back to them. So set the reward. But what we do as clinicians and as implementers is we provide the support or the coaching by using a lot of the elements of motivational interviewing in order to change systems, clinics, and individuals. And I will take any questions that we have here right now. Thank you.
Thank you so much, Prof. Altis, for the beautiful presentation. The floor is now open for question and answer. You can just turn on your mic and ask your question, or you can put it in the chat box.
So there's a question from Sten about what do you do for people, who have, missed 3 straight clinical visits and they haven't come back. And so they've fallen out of care, and it could be for addiction. It could be for, even retention in HIV care. And so this is really all part of the implementation. So I think on an individual level, you can, one of the things that we've done is we've set up texting reminders and just say, we've really missed you in clinic. We very much would like to see you. Even if it's just for a conversation, can we schedule an appointment? That's one way. So that is an implementation strategy that uses motivational interviewing. We can sort of set the stage up front. People love contracts. I'm going to give you this medication and I'm going to force you to not do X, Y, and Z, is to say that we recognize that things are hard. We have a team of people who may be able to help you, and we want to be able to help meet you where you are. And those are the kinds of texting reminders. It could be your outreach person that you send out, to meet the person. So I think that it's the language that you use and sort of recognizing that, that change is hard, but we're here to support you. And I think the word is support. In implementation, we often use the word coaching. But you're coaching them in order so that they can have a success. So Sten, I don't know if that meets your, answers your question, but that's what we do in, real world settings in terms of our texting reminders and how we engage with people is to sort of say, it's really tough. I'm sure life has been busy. We miss you. That sort of thing to say we like for them to come back.
Rick, you have 2 more questions.
All right, let me see if I can get through them. So let's see, I've got one from Zoom user. Is suggesting ways to help a client is a tough approach? If not, then what is? So I think if I understand the question correctly, suggesting ways, is that perceived as a tough approach? What I do is I try to get them to list the things that they can do first. And they go, and this is true. Sometimes they say, I've run out of ideas. I don't know what to do. And what, instead of saying to them, well, I think that you should do this, if I'm understanding this question correctly, that's not the way that I would say that we would suggest. We would say something along the lines of, well, you know, I've had other patients who've been in a similar situation, and one of the things that they've told me that works for them is X, Y, or Z. So it's the suggestion by offering up an alternative strategy that is not yours. I try to like make it external to me by saying, these are things that I've learned from my patients. I always try to make sure that my patients understand that I'm learning something from them from every clinical encounter. So if Zoom user wants to sort of ask me a clarifying question about that, I can, but that's my sort of quick response to that. And then I have another question. Thanks for the great lecture. I love the principles, the premises, the partnerships, and the process. My question is, which is always the important part, how can this be sustainable, especially in developing countries, if the interviewer is tired of giving the patients that need to be interviewed, you know, all of this stuff? It obviously takes a lot more effort. So I think the bottom line that we're getting at here is who needs to be doing that? And, you know, one of the things that Sten talked about earlier is the idea of task shifting. And I'll even broaden that a little bit further and say, you've got an array of resources that are available to you. And, you know, whether it is the medical assistant who gets trained, we train every single person within our clinic to be able to do some of this work, because sometimes they don't want to talk to the doctor. They're embarrassed about it, or they'll have these side conversations with the nurse who's doing, you know, the blood pressure. So one of the things that, you know, you can do is just say, well, gosh, that seems like it's something that's important to you. You know, haven't you spoken to the clinician, or can we get a time set aside so that you can speak to someone else? I get the fact that it takes a little bit more time. That's why I try to move to the 5-minute session. You know, motivational interviewing was set up for counselors who spend anywhere from 30 minutes to an hour. That's way too long for many of our clinical encounters. And so that 5-minute assessment, how important is it to you? Low importance, move to information. You know, what do you need to know? What would make you feel more, you know, interested in making a change? Those are the 2 quick questions, and not to go from a 2 to a 10, from a 2 to a 4. And then, gosh, you really do want to quit smoking. That's terrific. How confident are you? And then build the confidence. Gosh, I just don't know when the first day that I can do this is. Well, when was the last time that you faced something like that? You know, walk through some of this process. This can be a 5-minute quick encounter. The important thing is when they're motivated, invite them back. But I recognize that, and I wouldn't say it's just true for low and middle income countries. It's true in the US. I mean, you know, cash is king, and people are looking to make money, and they want to get them in and out. And this takes a little bit more time. So I agree with you.
Rick, one more question in the chat box.
Yep. Let me just see it.
I think a lot of clinicians, paramedics now are trained in MI, but how to ensure sustained practice of the MIs?
So that's a really good point, because, you know, I'm an MI trainer, and I catch myself from time to time falling into my own bad behaviors. And so I love this. So I think that we as clinicians is to sort of recognize that we have our own burnout, we have our own frustrations with all of these sorts of things. We're trying to do the best that we can. And so I sort of like have this sort of way that I push myself away from the desk. Now, I will sometimes, even in a clinical encounter, just saying, look what I'm doing. I'm doing what I'm not supposed to be doing. And then I sort of realign myself. The other way that people do this is through boosters, you know, sort of like bringing people together and supporting the clinicians, whether it's the paramedic, et cetera, to go back and say, okay, what kind of challenges are you having in sort of, you know, maintaining this? It must be frustrating, because we as clinicians have those same sorts of barriers and frustrations for our own change as our clients do. And so I think it's important to recognize that. And like, and motivational interviewing is not a one-time training. It requires coaching and support repeatedly. And so I would say just building that in. People feel better when you take a little bit of time to sort of go back over some of this, and they don't want to see the same principles again. They want the support saying, just like this question, I'm frustrated. how do we keep this up? I'm overwhelmed. And letting people sort of express that and sort of reinvigorating their interest, I think, is part of that. So that's my quick response to that. And of course, I'm really open to other people sort of saying what's worked for them to keep them, able to continue to do this. Oops, there's a couple more messages that cropped up.
There is a very good question, Rick. After COVID, most clients will be seen via telemedicine.
Yep. Yeah, so the question is I still think that whether it's an in-person visit or a telemedicine visit, you have limited time. And that's why I tried to move it to what I call the 5-minute MI assessment in order to really sort of at least start that process. So I think you can do that. And one of the things that's important to recognize, depending on how long your visits are, but in the US, many of these visits are 15 minutes. So if you have to give up 1/3 of your time to do the MI assessment, you're eating up at a lot of time. But it's really to say, gosh, we've gotten a lot done in 15 minutes, but I'd like to see you again and reschedule another appointment. And so that would be my take. But in our federally qualified health centers, people see somebody every 15 minutes. And then the other part of that is, if you have the ability to task shift and say, gosh, we've made a start here. I have a template in my medical record that actually has the importance score and the goal and stuff like that, just so that I can remind myself where they were each time. Because, last time you were here, your importance score was a 4. Today it's a 6. That's sort of celebrating their accomplishments. So I do think that you can do it, because I think a clinical encounter is 15 minutes, whether they're in person or not.
Hi, Prof. Rick. Actually, I've been monitoring the YouTube live now. So we have questions from the viewers from our YouTube session. So the question is, what if someone follows through the medical suggestion and appointments for a while, but later then disengage and with care because of HIV prevention treatment fatigue? So I mean, they've been doing good for a while, but suddenly this group feel just drop out and fatigue.
So when I showed that sort of, stages of change, they were doing well. They were in maintenance, right? They were sustaining what they were doing. But people slip back. We all slip back on these sorts of things. And so I think it's important to recognize. So I go back and say, gosh, you were doing so well. Things have gotten in the way. Let's go back and rethink what it was that made you motivated from before. I remind them, not by telling them, this is what you said, but I said, tell me about what was it that, got you going in the first place. So I use that reminder thing to figure out where they are. And most of the time I have to say is just stuff gets in the way. And then I sort of ask the question, what would need to change in order to sort of rework on this again? And they say, well, I need to get childcare. Okay. And then, if that's the plan, they do it. I can't afford it. What other sorts of things that you can do. So to really recognize that people who do well, I celebrate that success. My God, you did such a good job. And, you're having a different set of challenges now. How can we overcome some of those challenges? Or what can you do to rearrange the way that you take your medications or show up for appointments? One of the things that my patients told me that got them back into care is COVID. They got telemedicine. They didn't have to deal with transportation. And so I use all of those tools available. If a telemedicine appointment is the right one for them, I say, don't come to clinic, let's do telemedicine. But anyway, I just remind them of what successes they've had. And then I go back and they're at a different stage again. They're probably not going into pre-contemplation. They're probably in some kind of partial action. And they're just not really, they haven't gotten there yet. And I'd say, let's go back and you did really well last time. What did you do last time? What do we need to do this time?
All right, great. Actually, I have a question. So I think throughout all the thoughts that you share with us, the more focus is more on towards how we actually approaching our client or patient. So I think another thing that I like to highlight, the words that you say, don't assume, make the presumption about our client. But I think another aspect that probably we can think of, we always assume that our colleague or our in our field will accept whatever that we want to implement. For example, we talk about the earliest when we have the methadone replacement therapy, lead action program. Those who are in the area feel very enthusiastic to implement because we think that will help. But there are people in the same field as us. You know, we think that they are actually will be with us to help to promote. Now, recently, we have the issue like with PrEP. I think you know that, you know, those who are enthusiasts in HIV want to prevent, we really want to implement that. But those, we think that, you know, all the doctors, public especially, in fact, the infectious disease doctors also have a different perspective towards PrEP. So I think perhaps we can apply the same like MI approach also before we really want to announce that we're going to implement.
So part of what you're talking about is we need to use our motivational interviewing skills to get our doctors to do a better job. And then once our doctors are doing that, they can do a better job. But we also use our implementation skills to come up with better systems. You know, what's getting in the way of you doing this? Well, a person says, you know, I don't really think people need this, or I'm judgmental. And then, you know, sort of looking, but so motivational interviewing works at every single level here in order to, you know, to get change. And remember, there are going to be people who are pre-contemplative, no matter how much information you give them. With the COVID vaccine, I don't care what I would say, they would still insist that they were going to get metal particles inside of them. And you're not going to fix that on the first version. And after 3 or 4 people die, you know, maybe a few particles isn't so bad if the alternative is death. So, I mean, and even some of those people don't change. But we can really use the MI at every single level and, you know, to sort of impact change. And it's a great skill set. I have to say that it's single most important thing for me has been in raising my children.
So thank you so much, Prof. Altis, for the excellent presentation. And thank you for motivating us for your talk on motivational interview. You are a powerhouse, Rick. Thank you. So our next presenter is Sheila Shenoy, an associate professor of medicine.
Should we have a break, Romana?
You would like to take a break?
Yes, I think we usually we take a short break before the next session.
Sure.
Yeah.
So let's break the session for 10 minutes. We can get our tea and coffee.
Yeah.
And after the break at 11:15, we'll have Sheila Shenoy with his, I will welcome Sheila Shenoy for her talk. See you in 10 minutes time. Welcome back to the session. Last but not the least, we have Sheila Shenoy with us, an associate professor of medicine in the AIDS program of the section of infectious diseases at Yale University School of Medicine. Dr. Shenoy is also the associate director at the Office of Global Health at Yale School of Medicine. Dr. Shenoy has done extensive work to improve the clinical outcomes of those with HIV and tuberculosis. Without any further delay, let's welcome Professor Sheila Shenoy. Sheila, over to you.
Thank you so much, Dr. Romana and Prof. Adiba, and our condolences to her and her family. And thank you to University of Malaysia for this opportunity and for the opportunity to be a visiting professor. Very much looking forward to continuing our work together. I'm going to, add my slides.
Sheila, I think you faded away. Ravza, can you hear Sheila?
No, I think she's frozen in my screen.
My screen is black, yeah. Let me message Sheila, yeah. Okay, she's back.
Sorry for the technical issues. I'm not sure exactly what happened. Okay, let's try this again. Are you able to see the slides?
I can't see the slides, Sheila. Ravza? Oh, yeah, it's working. Yes.
Okay, wonderful. Okay. Thank you again for having me today. So we are going to talk now, I'll shift gears a little bit to talk about community-based service delivery and models that can optimize HIV care. Some disclosures that are not, no disclosures relevant to this presentation. So this is the brief outline of what we're going to talk about today. The focus here is community. And first, let's go into what is community and what does that mean. There's a couple different possibilities here, and then we'll talk about how we apply the concept of community to improving HIV care and outcomes in 3 different areas: HIV testing, ART initiation, and PrEP delivery. So let's start off by just talking about the emphasis on community. The UN Political Declaration on HIV and AIDS from 2021 focused on ending inequalities and trying to get on track to end AIDS by 2030. And they revise these guidelines and these declarations every few years. The most recent one was 2021. And in this session, there was a tremendous focus on increasing the proportion of HIV services delivered by communities, including ensuring that by 2025, community-led organizations deliver 30% of HIV testing and treatment services, with a focus on testing, linkage to treatment, adherence, retention support, treatment literacy, but also 80% of HIV prevention services for populations at high risk, and 60% of programs that support social programs. And that this should be the emphasis going forward on efforts to end the epidemics. And what do we mean by, this political declaration mean by community? They did provide some clarity here in terms of encouraging the strengthening of peer-led responses, scaling up efforts to promote the recruitment and retention of competent, skilled, and motivated community health workers, to expanding community-based health education. All of these were part of the community approach. Also, an emphasis on strengthening referral systems. So between community and primary healthcare services, for example. And a strong emphasis that underpins all of this on using delivery models, including differentiated service delivery models, to deliver treatment to people where they are. We have all certainly experienced, as clinicians, as healthcare workers, as public health professionals, the fact that people do not seek health services when, from our perception at least, that they need to. People have different competing priorities and demands on their time. They may not prioritize their health for a variety of reasons, and may not seek out health services in the formal healthcare sector based on their individual concerns and competing priorities. So there's accumulating data showing that we need to go to them. We need to go to where people are in order to engage people in health services and improve their overall individual outcomes and also public health outcomes. So what do we mean by community? There's a couple of different concepts here. So community can mean a social group or a group of living things that have some sort of commonality, including such as place or cultural norms or religion or values, customs, identity, any of these things, or multiples or combinations of these things that constitute a community. The other possibility is that communities share a sense of place or is focused on a geographical area. And in more recent years, it could be also a virtual space, depending on how we view it. So these are kind of the two main ideas around thinking about community. And how does that fit in to how we think about other structures in our society? So this is a very common social ecological model, and where we think about different layers to our health system and our overall society. So there's the individual level versus interpersonal or potentially families and other social networks that are more immediate to this individual. There's the overall organizational layer, which can be anything from schools or healthcare systems. There's overall community, and that here is defined more as like geographic neighborhoods, cities, counties. And then just how these all fit into the overall society that is bounded by federal, state, local, and policies and the overall systems that we are part of. So we're going to think more about what community means in this context. So community as a social unit, or again, as a part of a group of things where there are commonalities. We've all recognized there's incredible amounts of data indicating that these commonalities influence social and health-related behavior, and that includes HIV risk behaviors that we have all witnessed and seen in our clinical practice and on a public health level. There's a concept called social capital or social cohesion, basically the idea that connectedness, the sense of to our communities, and again, whichever commonality that maybe were relevant, increasing that sense of connectedness, increasing that sense of social capital can reduce risk and improve outcomes. And as it pertains to HIV, there's a plethora of data demonstrating that this to be the case. The more connected people are to their community, the less likely they are to have poorer outcomes. And there's multiple ways we can think about intervening in this sense of community and things that we do all the time. So this includes support groups, which may not be poised as an intervention from a research standpoint, but is definitely an evidence-based strategy to improve care. Other evidence-based interventions include peer navigation or mHealth apps that connect people, strategies to improve awareness or reduce stigma within certain community groups. All of these strategies can improve that sense of connectedness, improve the social cohesion or capital so that people who are at risk end up reducing that risk using various mechanisms. So now let's think about community as a venue. So community can be viewed as a physical setting, generally defined as just being outside of the formal healthcare facility. So this can manifest in different ways. So we can offer services in a community setting by clinical staff. Certainly clinical staff can go out to the community, perform outreach. There's services that can take advantage of lay workers or community health workers. And those community health workers can provide education, some maybe basic testing that are then refer people to the formal healthcare system. Could also manifest as services provided by community health workers or lay workers in a community setting, followed up by other services, again, in the community setting. And so basically all of those services taking place in the community setting, or services that are offered by lay workers, for example, and performed in community setting in combination with formally clinically trained personnel. So there's multiple different permutations of this that can take advantage of communities as a setting, taking advantage of community as a starting point that then refers to the formal healthcare system, or community as a place to do all of it. And again, these can take advantage of lay workers, they can take advantage of formal healthcare workers, or some combination. Okay, so let's now move toward talking about various community-based approaches that can improve HIV care and outcomes. And we're going to start off by talking about, I'm going to present to you some information about how community-based HIV testing is feasible, acceptable, and facilitates linkage to care. So this was a systematic review published a few years ago that demonstrates that community-based testing, the uptake of community-based testing for HIV, is substantially and significantly higher than testing performed at facilities. And you can see here on this part of this figure, all of these on the left-hand side of the figure are community HIV testing and counseling efforts versus facility-based HIV testing and counseling efforts. And these are about 120 studies that were reviewed. And you can see overall the percentage of testing uptake in terms of overall population that was offered versus population that took up testing in blue compared to the gold. You can see obviously that the proportion of people accepting testing in community settings as a whole, again the blue, was higher than what was seen in facility testing. And facility testing here is VCT, is voluntary counseling testing that patients sought out versus provider-initiated testing and counseling, PITC. So this review was focused on data from sub-Saharan Africa, pooled in the systematic review, and quite compelling differences in uptake of HIV testing. And again, uptake of HIV testing in a community setting can take various forms. They can be home-based testing that's administered by a lay worker or clinical professional, home testing that's self-test, mobile clinics, public health campaigns, workplace testing, or testing after an index patient has tested positive, so partner testing. So there's a variety of different forms that this can take. And in the same review, community HIV testing and counseling had not only high coverage and uptake, but they identified people with HIV at higher CD4 counts than facility testing. So here, the purple is the proportion of people testing positive, and the red is the proportion of people with CD4 counts less than 350. So overall, you can see that the proportion in facility testings is 65 to 70% have CD4 counts less than 350, much higher than what you're seeing in the community. In the community, you're seeing more people with higher CD4 counts rather than less than 350. And that's to be expected, but very useful to see that this is the case. Certainly, mobile HIV testing is very helpful, and home testing, mobile testing was particularly helpful with men, and men being a hard-to-reach population. And home testing with self-test reached the highest proportion of young people. So thinking about your population and approaching them with a suitable strategy is an important part of implementation. And I just wanted to highlight community-based services that we've seen in the US. And this is a nod to Prof. Rick. and work that he's been doing in New Haven, Connecticut for years, using a mobile healthcare van that makes the rounds in New Haven on a unique schedule, a dedicated schedule. So this study, a review of the clinical services that were offered among more than 8,000 clients, almost 30,000 visits. And amongst these services, which were not focused only on HIV services, of course, but expanded to offer a whole range of services, it gives you a sense of what people were looking for. Excuse me. So more people who were more likely to take advantage of services were people who were foreign born, people who were using injection drugs, and people who had hypertension. And this is important to understand the range of services that people are interested in and would take advantage of on a community level. And I want to say this work has been, seeing that work in New Haven has been personally inspiring to me and has led to some of my work in other areas. So I'm going to tell you a little bit about work that I've done with colleagues in South Africa, where there's a strong focus on community-based approaches. And I worked with colleagues to look at intensive case finding. And this was tuberculosis integrated with HIV case finding. And this was in partnership with the Department of Health, where we developed a team of nurses, HIV counselors, but also lay health workers to go out into the community to perform symptom screening for tuberculosis, to perform HIV testing, rapid HIV testing on site for people who were positive. We were able to perform CD4 count as well, phlebotomy for CD4 count. With the input of the local Department of Health, we incorporated random blood glucose and automated blood pressure screening, and went out to the community, various sites, and offered these integrated communicable and non-communicable disease services using a mobile van, as you can see pictured here. So overall, we targeted congregate settings and screened more than 14,000 people. And I'll say that these are photos of different sites that we went to. So that includes a taxi rank or a place where buses would converge and people could go from point A to point B and switch to another bus and go off to another location. Events organized near people's homes by lay workers, municipality events, where we were able to be part of with our local government, secondary schools, and places where people got their grants. The emphasis being on group level education, not only on HIV, but on HIV, STIs, pregnancy, diabetes, hypertension, really whatever people wanted to hear about. And then individual level counseling in a private setting. And I'll say that these sites were chosen based on my local South African partners' input and recommendations, which was key, building on something that Prof. Sten said earlier. And I'm going to focus here on the HIV testing results. But over the first 5,000 people that we encountered in the community, there was 91% uptake of HIV testing. Found nearly 1 in 10 people were living with HIV. We were able to perform phlebotomy in the community for CD4 count. And we identified that the median CD4 count was overwhelmingly on the higher side, 382. And most people, similar to that review, were identified in the community at a higher CD4 count. So this demonstrated the feasibility of such an approach. And we were able to refer and link to care those who we identified as HIV positive. And to build on this, we provided services at these various congregate settings. We identified on the review of our data that we really were missing one particular group, and that was young men. who may have been present at these community congregate settings, these community venues, but were not partaking of the services. And we also tried switching to home kind of testing, including training community health workers to go to people's homes. And that also had a similarly high uptake for testing, but similarly, we were not seeing testing occurring in men, and particularly young men. And so based on our local colleagues' input from my colleagues in South Africa, the idea came to target men where they are. Again, going back to that theme of going to where people are. And looking at the various venues where men spend their time outside the home, shebeens or bars rose to the top of the list. And so we applied the same strategy, providing non-communicable and communicable integrated screening in the form of a health checkup, which was very appealing to community members. We took that same strategy and applied it to bars or shebeens. And the other thing that may have been that we adapted slightly was to provide gender concordant care. So we focused on providing services by male community health workers and male nurses. We did this in the off hours and to when people were more likely to be attending bars in the evenings, late afternoons and evenings into the night. And for those people that we identified with HIV, we offered linkage to care, and that could have been physical escort or the next day or a referral, depending what the community member wanted. So this was an initial description of the work that we did there. Screening more than 1,300 people, overwhelmingly men, because culturally, people who go to the shebeens are predominantly men. It's still somewhat taboo for women to go to bars, formal bars. Women tend to drink more at home, although that, again, is changing. Again, the vast majority of people were men in this effort, which was really exciting and appealing to the Department of Health when working with them in South Africa. 1 in 7 of the people that we engaged had never been to a clinic. And we ended up identifying 11% more than 1 in 10 with HIV. We linked people to care who successfully were able to obtain the CD4 count and initiate ART. Through this work, though, we did identify some of the barriers that community members and participants provided. Certainly people recognized, and particularly our staff, recognized the role of excess alcohol use and alcohol use disorder on people engaging with these services, people linking to care. Certainly transportation was an issue. This was a very poor area in a very rural, geographically widespread region. And people didn't have necessarily money to go to the clinic. So recognizing these context-specific barriers brings us to what has been recognized in a lot of regions, and that's the benefit of providing community-based ART initiation. And what I'm going to present to you next is data that demonstrates that community-based ART initiation is feasible, acceptable, and improves viral load suppression. This has been a very exciting field to watch over the last several years. So this, I'm going to start off with the DUART study. So formally named community-based ART versus standard clinic-based services for HIV in South Africa and Uganda, nicknamed the Delivery Optimization of ART, or the DUART study. So this was, the investigators enrolled more than 1,300 people with HIV and randomized them to community-based ART initiation versus clinic-based ART initiation in Uganda and South Africa. Lay counselors were the ones who did HIV testing with standardized pre-test and post-test counseling. There was offered couples counseling and facilitated disclosure. People with HIV received additional point of care testing. So again, all in the community to stage their HIV. So CD4 count, WHO clinical stage, pregnant point of care pregnancy test, point of care creatinine testing for renal function, and symptom screening for tuberculosis. And then people were randomized to receive one of three arms. One was just straightforward community-based care, where all of the services, the testing, the ART prescription delivery, refills, monitoring, follow-up testing, viral load testing, all of that was happening at a community level. A hybrid model where people may have been tested in the community, but they went to the clinic to start their care, and then continued their care in the community later on and follow up in the community. And then wholly clinic-based care according to standard protocols in both South Africa and Uganda. And they looked at overall the primary outcome overall was viral load suppression at 12 months. And overall, at 12 months, community-based ART increased viral load suppression compared with the clinic group. So the overall risk was 1.18, and this was very exciting. And in particular, I'll point out here that the community-based ART retroviral therapy benefit was even higher for men overall. And there was other site differences between men and women in South Africa, for example, between the different sites, more benefit in South Africa than in Uganda, for example, and by more important for people over the age of 30, for example. But overall, I think this demonstrated the value of taking a community-based approach for ART initiation and moving away from solely formal brick and mortar services in the formal healthcare system. Next, I want to mention the POPART study, population-based ART study. So this is formally named the Effective Universal Testing and Treatment on HIV Incidence. This was a study published in the New England Journal, again with a nod to Prof. Sten, who was part of the study, the investigative team. Quite a staggering and impactful study. So this was 48,000 participants in 21 communities in South Africa and Zambia from 2013 to 2018. And community health workers provided a lot of the services in the community. They were trained to provide HIV rapid testing at home. They provide linkage to care and ART adherence for the people who tested positive, people who were identified with HIV. They were referred to formal clinics. In addition to that, they referred uncircumcised men who tested negative for voluntary male circumcision, and women who tested positive and were pregnant for antenatal care, including ART and prevention of mother-child transmission for services. In addition, these community health workers screened community members for symptoms of TB and then referred people who had symptoms for diagnosis to a clinic and potential treatment. They screened for STIs and with referral as well, and they promoted and distributed condoms as well. And just to emphasize, all of the HIV care and ART was provided at the clinics. So really it was the community health workers who were going out and doing the screening, the initial testing, and identification of people with HIV and people who were at risk. So overall, the ART coverage at 3 years was quite high. In Arm A and Arm B. So in Arm A, ART was given to everybody, regardless of CD4 count, more consistent with current guidelines. But this was in 2013, before some of these guidelines changed. And Arm B was ART given to people according to CD4 count less than 350, and eventually that changed to 500. And then eventually changed to all. But the overall viral load suppression was quite high at 2 years. Overall, the intervention arm, which was Arm B, with ART for local guidelines, reduced HIV incidence by over 30%. So this is quite striking. Before we just move on to the next slide. So I think the incidence overall was not affected, and that was attributed to changes in standard of care that were given in the control arm, changes in CD4 count thresholds. But overall, it did show a tremendous impact on incidence and what was feasible at a community level that could have population level impact. And then the last thing I'm going to talk about here is with regard to ART initiation is the SEARCH study. So HIV testing and treatment with the use of a community health approach in rural Africa. And this was another study that was published in a very prominent journal that focused on Kenya and Uganda, where they conducted mobile 2-week multi-disease health campaigns in collaboration with the local government, identified communities that were that were subsequently paired and randomized. So one pair of the community, or one community of the pair received baseline HIV testing and multi-disease testing at health fairs and were given ART according to national guidelines. And that was a control group. But then the other community in the pair received HIV multi-disease testing plus annual testing. People were eligible for ART regardless of CD4 count, no restrictions. And they received patient-centered care. And there were multiple ways that they did that. And they looked at the overall cumulative incidence of HIV infection, whether or not this had an impact. So this was, pretty impressive impact. The population viral load suppression was higher in the intervention group. So the groups that were getting unrestricted ART, annual testing, and patient-centered care in the intervention group compared to the control group. Furthermore, the incidence of HIV infection in the intervention communities decreased by 1/3. That's astounding. Ultimately, the cumulative incidence didn't differ between the groups. As I mentioned, similar to the previous study, was attributed to changes in ART access and availability. But again, the overall impact on incidence and impact on achieving viral load suppression is quite impressive. And then certainly expanding beyond HIV, another impressive point from this study was the fact that people who were identified with prevalent hypertension and were referred for, and everyone was referred for services if identified to have elevated blood pressure and screening in the community, 26% higher control of blood pressure, or control of hypertension amongst the intervention group compared to the control group. And so, just to make the point that we need to apply some of these strategies beyond HIV, encompass integrated services, and that's really going to enhance uptake and benefit other conditions as well. And then the other thing just mentioned from the study that, again, they didn't achieve their primary aim in terms of overall incidence compared to the control group, but the overall probability of death among adults with HIV was 23% lower over 3 years by using this intervention. Incident tuberculosis was 20% lower in the intervention group compared to the control. And overall incident rate of TB at 3 years among people who were HIV positive was lower by almost 60%. So getting people, going to the community, identifying people with HIV or with other co-infections or with non-communicable disease, definitely, and providing referrals care, linkage to care, definitely had a strong impact on outcomes, even at 3 years. Okay. So next, we're going to switch gears now and talk about how community-based PrEP delivery is feasible and acceptable. And this is a relatively new area. We'll talk about a little bit about what's out there. So that same study that we were just talking about, the SEARCH study, Kenya and Uganda, where they had such an impact on multiple levels. In addition to the focus on testing and ART initiation, they, for the people who tested negative, they offered PrEP. So again, going back to the study, there's like more than 70,000 people who were tested. There were 69,000 people who tested negative, 12,000, almost 13,000 who had elevated risk according to local guidelines, and that were offered same day or rapid initiation of PrEP through a local government clinic. Now, the study did provide a one-time transport to the clinic to facilitate this linkage. At the clinic, people were provided information about PrEP, the risk score, assessment-based assessment for risk. They were offered testing, but all the PrEP itself was offered to the clinic. So all of that in pre-assessment, pre-PrEP assessment was done in the community, but the actual prescription and clinical initiation of PrEP was done at the clinic. And you can see here through this cascade that of the 3,500 people who initiated PrEP, only about 64% of people were still on PrEP 4 weeks later. And overall, about half were still taking it at 72 weeks. But the idea about feasibility is still there. And most of the people that were lost over this time were young people. And so it makes us think about what parts of this implementation are going to help people be retained in care on PrEP. And so I'm going to tell you just a little bit as we wind up here, a little bit about my own experience with community-based PrEP delivery. So as we mentioned earlier, targeting men who are less likely to engage in HIV prevention, HIV testing, treatment, and prevention services, so HIV services across the cascade, and have been marked as a priority group by UNAIDS. Community-based services may be particularly appealing. Again, trying to go to where people are. In this community in rural South Africa, shebeens or bars was a particularly common place for men to spend their time. And so going to shebeens to offer these services. So I mentioned before about going to shebeens and offering HIV testing, linkage to care. So, but building on that platform, we offered PrEP services in the same way. So similar as before, we had an all-male community health worker team and nurses who engaged men as they were going into bars before they started drinking. And the comprehensive health screening included both HIV, TB, and non-communicable disease testing. And people who tested negative for HIV that were eligible for PrEP according to local guidelines were offered enrollment. We initiated PrEP not that day, but on another day they had a clinical evaluation, went through testing, for example, for renal function, and then started PrEP. People were supplied 1 month of medication. They came back a month later. As long as everything was well, then they received their next 3 months supply according to PrEP protocols. And subsequent PrEP was delivered by the lay workers, either to their home or to another mutually agreed upon place in the community. So patients did not have to go to a clinic for any of these services. And this is just some examples of our mobile clinic and people, our staff, this person in the light blue t-shirt, engaging people outside of a shebeen, to bringing them into the mobile clinic to do the testing. This is a student who worked with our team. And you can see the squares in blue are what's happening in the community before initiating PrEP that all took place at the mobile clinic. And then the parts in green where once people accept referral for PrEP and want to start the clinical process for PrEP initiation, that all happens at a non-shebeen community location. According to what the preference of the participant. So we could meet them at their home, we could meet them, at the community center, at our offices, really whatever people preferred. And overall, this was a small pilot, but overall 68% were retained in care at 1 month, which is similar to what we saw in the search study, and 30% were retained at 4 months. And the main predictors of uptake amongst this group included increased number of sex partners over time and people who have never been to a primary care clinic. So this kind of approach does align with community members who do not go to the formal healthcare setting. So it's, again, meeting people where they are and offering them services in a way that's appealing and convenient for them. So this our evaluation demonstrated that this was feasible and acceptable, even despite the disruptions during the COVID pandemic. This particular approach was focused on shebeens, which during COVID were shut down several times when there was a COVID surge. And also during this time, during COVID, certainly risk behaviors and overall practices changed. Our internal feedback that was done qualitatively, participants were very excited and satisfied with this community model of services. They felt it was very convenient, and that really facilitated them starting PrEP and continuing to take it. They really didn't want to go to clinics. Men reported the fact that there was gender concordant care, or male lay workers and male nurses, was very important because they felt that they was able to engage well with that team, as opposed to going to see nurses who run the primary care clinics. There's a lot of stigma and perceived judgment when they go to a formal care clinic. The participants did report that there was a couple of people who reported concerns about privacy. They felt like there was peer pressure to reveal what their HIV test was because they were there doing it, at a social venue, the bar, with their friends around them. And so trying to incorporate that feedback into how we improve this in the future is important. And certainly the men who participated wanted us to expand beyond the bars to other community sites. And they also requested assistance with disclosure of their HIV status, disclosure of PrEP use. So that gives us lots to think about. So overall, community-based approaches are feasible and acceptable. I hope I've been able to show you that. In terms of lessons learned, I think it's important, and I think this builds a little bit on what Prof. Sten was talking about earlier, that it's important to engage your local stakeholders. You may think you have the answer, but it's very important to engage the people who are living this every day. And that includes the end users, the community members themselves, people from various risk groups, and that includes people who are providing the services. And those could be NGOs, those could be clinicians at the formal healthcare facilities, but across the spectrum, getting that input is key to determining the appropriate strategy. Strategies that are selected and implemented need to be context specific. So certainly, as we've talked about, there's geographic context, and I'm not just talking about Malaysia versus the US versus South Africa. I'm also referring to rural versus urban, for example. What is around them? What is available in terms of access? Next, cultural context. I think Prof. Sten mentioned something about the fact here in Malaysia, you have multiple different cultures that are integrated in daily life. But when we're talking about health services, there might be things that are more important to one population versus another in how you approach them, especially with regarding to certain health topics. And that needs to be kept in mind. In the gender context, there's in most cultures, there are strong gender domains. And keeping in mind now other genders than what we think of as traditionally male and female, but thinking about non-binary as well. And keeping all of those in mind as you develop your interventions, making sure that the intervention is going to be acceptable from a gender standpoint. And all of these things, all these contexts are important to consider when developing a differentiated care model. That's going to be specific and ultimately appeal to a certain health context or health condition, certain populations. And the last thing that I mentioned is that successful implementation is a process. You're not going to arrive at an answer, implement it, and then be done. It's a continuous process of monitoring, evaluation, and feedback that are key to success and key to improving outcomes. So I hope I've been able to share with you evidence on community-based approaches, scaling up of implementation of HIV testing. There's a tremendous amount of data on the success and feasibility of HIV testing at a community level. So I think at this point, it's more scaling up those approaches. Again, using the appropriate context for different populations. Certainly developing differentiated care models to strengthen implementation of community-based antiretroviral therapy. It needs to be contextualized for which population you are targeting. When we're talking about HIV prevention, this is still relatively new. And so generating more evidence to show feasibility, acceptability in different populations, showing impact, how can we adapt or revise our strategies to keep people in care? What can we do to not only initiate, but retain people on PrEP? And this may require differentiated care models. We need more information on how best to do this. And I think I mentioned this earlier, but just to reiterate, these same approaches that we're using for HIV can be applied and expanded to non-HIV efforts, including non-communicable diseases, or other other communicable disease conditions that can be very easily integrated into this approach, and in a lot of ways potentially is even more appealing to community members when they can get multiple services integrated together that benefit them. So I will leave it there, and I want to say thank you for having me, and I welcome any questions.
Thank you very much, Sheila, for the very enriching presentation. The floor is now open for question and answer. You can type your question in the chat box, or you can use your microphone.
I see one question from Prasten. Thank you for that question. Did you have success in mainstreaming the Shebeen bar-based services for testing and PrEP, getting the local health services in South Africa to include this as routine care, or is this still in a demonstration project? So what we did was a demonstration project. We have presented this recently to the South African Department of Health. They've been very excited about it. And I think they're trying to decide how they can take this on. When we've presented previously our work in the community at congregate settings, they very much appreciate that. We're excited about that. And in fact, they've been key partners in all of this work, providing input along the way. They did start doing community-based screening at the congregate settings to start. That was our initial work. And they had posted, at least pre-COVID, they had posted nurses in the community to at largely focusing on the taxi ranks, so basically the bus stations. So lots of people going back and forth, and lots of traffic through that area, through those bus stations. So they saw that as the most valuable source to them, the most feasible from their standpoint in terms of scaling that up. So that was really going well prior to COVID. I think things have obviously gotten very much disrupted since COVID, and they're getting that back on track. In terms of the Shebeen focus, again, they very much like that. They're very excited to see how many men that we were able to engage using this approach. They're still considering how best to scale that up. I think this is very much focused on not only the venue, but the fact that we incorporated male-only teams to engage men, in the community. They have taken up that part of it by scaling up the number of men at some of the primary care clinics. And so directing community members to those specific clinics for men to see male providers. And so whether or not they move that to a community focus as well, I think remains to be seen. I think there's some operational issues there. For example, we were focused on most of the traffic at Shebeen's is in the evenings and during off hours and weekends. And so employing government personnel to do that work and during off hours presents a logistical challenge, not insurmountable by any means, but requires further thought. Thank you, Dr. Amana. A successful implementation is an ongoing process. Do you think resource scarcity can be a challenge? Yes. Often this is a challenge. Certainly we want to always think about resources when we're developing new strategies, implementing new strategies, and we want to do this in a most sustainable way. Long-term sustainable strategies often need to be done with the formal healthcare system. And so engaging our ministry partners is important, or engaging other long-term and invested partners in how to make these happen is important, so that it can be scaled up throughout the healthcare system, or revised as appropriate according to the ministry's priorities. But the idea that the implementation evidence is presented is key. Prof. Steenis, it sounds like the South African studies do for more implementation science research. Yes, yes.
Any other question from the participants? So we have come to the end of this webinar, and we would like to express our gratitude to the distinguished presenters, the Yale professors. Very rarely we get an opportunity to have Prof. Stein, Prof. Rick, and Prof. Sheila on the same platform. So thank you for making that possible. This was a joint effort by Prof. Ravza and her unit, CEBP and CHIRIA. So I would like to thank Prof. Ravza and all of her colleagues at CEBP and my colleagues at CHIRIA. Last and the most, I would like to thank all of the participants for taking time and joining this session. So we reached, I feel very happy to let all of you know that we reached the maximum capacity of this platform, and we had to redirect many participants to the YouTube channel. Just to let all of you know that we were streaming this live on YouTube. With that, I would like to thank all of you one more time. Any final word from Prof. Ravza, Prof. Stein, Prof. Altis, or from Prof. Sheila?
Yeah, from me, I would say again, thank you to all the three speakers. I think we can spend hours to listen to them speaking about sharing their experience and knowledge. I think every time I'm here, I learn a new knowledge from them. I think especially like Prof. Rick, Prof. Stan, I think I can stay up like 3 o'clock in the morning to listen to your talk. I think all of you giving a very wonderful talk to us. And then again to all the participants, I think from all over Malaysia, I mean, joining us through Zoom and through YouTube session. Thank you for your time. And we hope that you enjoy the session and learn something from the session. I think maybe we can have a quick photo session, Romana, for whoever available and have their camera ready. Maybe you can put your camera on. We can have a quick photo session. So I hope
camera will take few photos.
Anis, are you there to help with the photo shoot?
Yes, I'm here, bro.
Maybe you just give a few hint count for us to get ready. Yeah.
Right, so I will screenshot at 3, 2, 1, 6. Okay.
Maybe we have to go to like few page again because we have like page 2 and page 3 so.
Okay, another one. 3, 2, 1, click. All right.
See, when they open the video, you can see like many of them joining, even though they're using one user. Very happy to see all the faces joining us. I think if you still have questions later on, if you not sure about certain issue and ask, please do contact us. We can direct you to the expert to help you. Either you want to conduct research or you want to implement something or to design a program. We are happy to help you. Any last word from Prof. Rick? Prof. Stan? Okay, Sheila, anything last word?
No, I just want to say thank you very much for the opportunity. It's been a wonderful session today. Every time I listen to Prof. Rick and Prof. Stan, I learn something more. So it's always a treat.
So Malaysia will be looking forward to listen more from Prof. Stan, Prof. Rick, and Prof. Sheila. We missed.
And I'll just add, as Sten said at the beginning, you know, we're here. We're happy to meet with people. We're happy to work with people. We're going to be here this week, maybe send a little bit longer, and we're all going to be back in July. So anyway, keep us busy, make us earn our keep here. We love coming here.
Thank you. Bye, everyone.
Okay, thank you so much. All right.